Good morning, everyone. I would like to welcome you all to the 51st Annual State Conference of ORIA 2025, hosted by AIMS Bhubaneswar. We'll start with our paper presentation. I would like to introduce our judges. We have Dr. Suprabha ma'am, Dr. Sudipta ma'am, Dr. Jayashree ma'am, Dr. Feni sir, and Dr. Gitanjali ma'am. So without any further delay, I would like to call Dr. Anirudh Venkat, whose paper topic is Association of Histopathological Grading and Clinical Staging of Cervical Carcinoma with Diffusion Kurtosis Imaging.
Good morning, everyone. My name is Anirudh, and my title is Association of Histopathological Grading and Clinical Staging of Cervical Carcinoma with Diffusion Kurtosis Imaging. Introduction. Cervical cancer remains one of the most common malignancies among women in India and worldwide. For optimal management, it is essential to know both the histopathological grade and clinical stage before treatment, as these guide therapy and prognosis. DWI helps, but it assumes that water diffusion follows a Gaussian pattern, which is often not true in case of complex tumor tissue. Diffusion kurtosis imaging, or DKI, goes a step further by quantifying non-Gaussian diffusion, providing parameters like mean kurtosis and mean diffusivity, which reflect tissue heterogeneity and cellular microstructure. By studying DKI parameters in cervical carcinoma, we aim to see how these imaging biomarkers would show association with tumor grade and stage, and how they can add value beyond the conventional MR. DKI quantifies the degree of non-Gaussian diffusion by measuring diffusional excess kurtosis. When we use DWI imaging, we assume that water molecules diffuse freely and randomly in all directions. Their motion follows a Gaussian normal probability distribution, that is unrestricted symmetrical diffusion. A Gaussian distribution is a bell-shaped curve, also called a normal distribution. This is a bell-shaped curve. In real biological tissues, including that of tumors, diffusion is not truly random. Water molecules encounter barriers like cell membranes, organelles, fibers, and extracellular matrix. This causes restricted and complex diffusion. The resulting motion deviates from the simple model, becomes non-Gaussian, and it is represented by a peak curve. This is a peak curve. The difference between the peak curve and the bell curve is what is kurtosis. Kurtosis is the difference between the bell curve and the peak curve. Diffusion kurtosis imaging quantifies the deviation using mean kurtosis, reflecting tissue heterogeneity. The primary objectives of my study are to determine the association between diffusion kurtosis imaging parameters and histopathological grading, that is well differentiated, moderately differentiated, and poorly differentiated, and to determine the association between diffusion kurtosis imaging parameters and clinical staging. The secondary objectives are correlation of DKI parameters between normal myometrium and carcinoma cervix. Materials methods. Study design includes around 40 patients, and it's a clinical cross-sectional analytical study. Place of study will be our department, and study duration of 12 months. Inclusion criteria will be all patients having recently diagnosed uterine cervical cancer. Exclusion criteria is usually the usual normal MR exclusion, like pacemakers or metallic foreign body implants and history of claustrophobia. Materials and methods. Pelvic MR scans are performed using 3 Tesla imaging MR machine. Standard pelvic MRI protocol will be performed and will include the addition of a DKI sequence for advanced diffusion assessment. Those having FIGO stage 1A, 1B, and 2A will undergo surgical management. We will compare MR findings of these patients with the histopathological findings post-op. We will also compare the MR findings of these patients, of all patients, with that of normal myometrium. Mean diffusivity, mean kurtosis values are derived from DKI sequence and are analyzed for correlation, histopathological grade, and clinical stage. These are some images taken from our hospital, which this is a T2 sagittal image, which shows a large hyperintense T2 hyperintense lesion involving cervix, which shows avid post-contrast enhancement. It shows hyperintensity on DKI image as well, and this ROIs will be marked on the DKI image, and from there, MD, immune diffusivity, and mean kurtosis values will be extracted from that. This is another case showing a similar CA cervix lesion, which is showing contrast enhancement, and then the final image on DKI. This is another similar CA cervix case. Results. Mean diffusivity of cervical carcinoma was significantly lower than that of normal myometrium. The lower MD in cervical carcinoma was likely related to the restriction of free water diffusion. The mean kurtosis of cervical carcinoma was significantly higher than that of normal myometrium. And the higher the differentiation degree of cervical carcinoma, the higher the MD values and lower the MK values. There were statistically significant differences in MK values between the two groups of cervical carcinoma with different degrees of differentiation. Here we can see how the MD values increases in case of, MD value decreases in case of CA cervix, and how the MK value increases in CA cervix, because reflecting tissue heterogeneity. On ROC curves, the orange MK line provides the best combination of high sensitivity and specificity. The curve remains well above the diagonal line throughout, suggesting high diagnostic accuracy, and it is better than MD. In the differential diagnosis of high and moderately low differentiation of cervical cancer, the area under ROC curve is high, and the sensitivity or specificity were also good. Application value. Provides a non-invasive imaging biomarker for assessing tumor grade and stage in cervical carcinoma, may help in pre-treatment prognostication and individualized therapy planning, could reduce reliance on repeated biopsies for assessing tumor aggressiveness, potential role in monitoring treatment response or early detection of recurrence, which can be a future application, and adds to the quantitative imaging armamentarium in gynecological oncology, and generates baseline data for Indian population where limited studies exist. Conclusion. To conclude, DKI adds a new dimension to conventional MR by quantifying tissue heterogeneity. The observed increase in MK and decrease in MD with high tumor grade and stage suggests that DKI can be a valuable, non-invasive tool for better assessment and management of cervical carcinoma. These DKI parameters correlate with increasing tumor grade and FIGO stage, reflecting tumor aggressiveness. Incorporating DKI into pelvic MR enhances diagnostic and staging accuracy in cervical cancer. These are my references. Thank you. Ma'am, we have a post-processing tool, and we mark the like the post-processing tool is outside the department. We send the values to that person, and he senses the values. The mean diffusivity and mean kurtosis values we get from that person.
You have taken the volume or a single ROI?
No, single ROI, ma'am. Single
only from single area?
Single ROI, I use it on the lesion and on the normal myometrium.
Which part of the lesion you took?
The
CA cervix, you showed us one image.
Yes, ma'am.
It was a very large
Yes, ma'am.
image. So from where you took this?
From the center part of the image, which is most bulky and
Anything
hyperintense.
like you excluded from which place I will not take the ROI? I will not plate.
That I have not done. I made sure that it doesn't. I made sure that it comes one comes from the normal myometrium, one comes from the CA cervix part.
Okay.
Okay. Thank you.
Thank you, Dr. Anirudh. Now I would like to call upon Dr. Anvi Sachin, whose topic is Beyond the Pulse, Visualizing Takayasu Arteritis in Contrast.
Good morning, everyone. My topic for today is Beyond the Pulse, Visualizing Takayasu Arteritis in Contrast. So Takayasu arteritis is a chronic granulomatous vasculitis involving aorta and its major branches and having younger female predominance. The disease progresses in two phases. The first phase is a systemic phase which has generalized symptoms such as fever, malaise, syncope, while the other phase is chronic phase, where typical symptoms such as different BP in both arms, absent or weak pulses, and limb claudication, etc. are seen. Therefore, CT angio is vital for early and accurate assessment as well as classification of Takayasu arthritis using Hata et al.'s classification for standardized and proper treatment. So our aims and objective for this study was to evaluate the role of CT angio in the evaluation of Takayasu arthritis and to apply the Hata et al.'s angiographic classification for the accurate assessment of arterial involvement and also to correlate the CT findings with the clinical features for proper and effective management. So 30 patients, 18 females and 12 males were evaluated over 3 years in KIMS who were known cases of Takayasu arthritis or had clinical symptoms suggesting the same. They underwent CT angio and were reviewed and classified based on Hata et al.'s classification. CT was done using 64 slice GE Optima CT660 and iopramide was the contrast which was used. So this is the new Hata et al.'s angiographic classification for classifying Takayasu arthritis. Here we can see if only the arch vessels are involved and not the arch itself, then it is type 1. If ascending arch and the arch are also included with the arch vessels, then it is type 2A. If the involvement is in the descending thoracic aorta also, then it is type 2B. If only descending thoracic aorta and abdominal aorta are involved, it's type 3. And type 4 includes the involvement of abdominal aorta plus minus renal arteries. And if everything is involved, starting from the ascending arch to the abdominal aorta and renal arteries, it's type 5. So now we'll see one representative case for each type. For type 1, we have a case of 16-year-old male presenting with complaints of intermittent fever, pain in left upper limb since 2 weeks. And in the CT angio images in MIP mode, we can see there is luminal narrowing and partial stenosis of the distal first part and second part of the left subclavian artery in the axial, oblique coronal and coronal images. The second type 2A, we have a case of 32-year-old male presenting with the complaint of giddiness, syncope, speech disturbance, and he was diagnosed to have right MCA infarct and underwent right CCA stenting later on. So in this image, we can see marked with the red star, we have the concentric wall thickening of the arch of aorta. Here we can see concentric wall thickening in the right brachiocephalic trunk and partial occlusion of the left CCA and complete occlusion of the left subclavian artery. Same we can see in the MIP images, and this is a post-intervention stenting phase where we can see the stent in right common carotid artery. For type 2B, we have a case of 28-year-old female presenting with complaints of seizure, headache, visual disturbances in both the eyes, and patient also had a history of premature cataract in right eye. So in the first image, we can see wall thickening around the brachiocephalic trunk. In the next image, it is an oblique coronal CT angio image, where we can see there is near complete occlusion of the left proximal CCA and complete occlusion of the first part of left subclavian artery. Then here we can see the involvement of descending thoracic aorta, which is ending at the thoracic aorta and it's not involving the abdominal aorta. And in USG Doppler images, we can see concentric wall thickening, which is also known as the Macaroni sign, and luminal narrowing in the left CCA. For type 3, we have a case of 44-year-old female presenting with complaints of left lower limb claudication, hypertension, and syncope since 1 month. In the sagittal images, we can see calcification starting from the descending aorta and the abdominal aorta, sparing the arch of aorta, which makes it type 3. Then in the axial images, we can see concentric calcification and wall thickening in the descending aorta. For type 4, we have a 27-year-old male presenting with complaints of hypertension and pain in abdomen. CT angio showed partially thrombosed aneurysm, which is shown by the red star in coronal, axial, and sagittal images. And with the yellow arrow, we can see the aneurysmal dilatation of the abdominal aorta. Since only the abdominal aorta is involved, it is type 4. Here we can see the 3D image of the aneurysm, and this patient underwent hybrid endovascular aneurysm repair, which we can see the stent in X-ray, CT, and in the DSA images. For type 5, we have 2 cases. First case is a 50-year-old male presenting with complaints of headache, different BP in both arms, visual disturbances, and hypertension. So in the first image, we can see the involvement starting from the arch of aorta and to the descending and abdominal aorta. Here in image B, we can see in oblique coronal CT image, the involvement of the arch vessels, where we can see luminal narrowing of the brachiocephalic trunk and complete occlusion of the left CCA and left subclavian artery. And also further below, we can see mild stenosis of the left renal artery and complete occlusion of the right renal artery, which caused resultant hypoperfused and contracted right kidney. Second case, we have a 28-year-old female presenting with complaints of pain in chest and abdomen and hypertension. In the axial image, we can see CT angio showing wall thickening and luminal dilatation of the abdominal aorta. Here we can see bilateral CCMA wall thickening, right more than left. And the ascending aorta and the thoracic and abdominal aorta, we can see the aneurysmal dilatation. And same we can see in the coronal and 3D images. So we can see clear young female predominance in our study, having 60% of females and almost 63% of the patient being in the young age group of 20 to 40 years. And the mean age of our study was 32.3 years. Among the 30 patients evaluated, the type 5 was the most common finding, while type 1 was the least common. And while echo 2D correlation, we found the most common finding was left ventricular hypertrophy and tricuspid regurgitation. And the systemic involvement was the CNS system, peripheral vascular system, renal and ophthalmic systems. Unfortunately, 3 patients succumbed to death during the course of follow-up. So Takayasu arteritis is a chronic large vessel vasculitis, and CT angio is a reliable gold standard investigation. Based on the Hata et al. System, type 5 was the most common, as we got in our study and in the literature as well. And so Hata et al.'s classification serves as an effective communication bridge between the radiologist and clinicians for proper and early management and treatment planning. These are my references. Thank you.
How you will assess the disease activity in case of Takayasu arteritis?
Ma'am, CT angio is a gold standard, so we can see the extent of the involvement, either of the wall thickening or the calcification on aneurysm, and we can base it on the classify it on the basis of Hata et al.'s classification.
Any lab parameters you depend on for activity of Takayasu?
No, sir, we didn't do in our study. We used the clinical correlation by the clinical symptoms and echo 2D correlations. But clinical parameters as such weren't any.
Okay, next.
Thank you, Dr. Anvi. Next, I would like to call upon Dr. Atharva N. Deshmukh, whose topic is Saving Seconds, Saving Lives, the role of CCT in hidden blunt trauma.
Good morning, everyone. My topic for paper presentation is Saving Seconds, Saving Lives, the role of CCT in uncommon finding of blunt trauma. Traumatic injuries are a leading cause of death in individuals aged 12 to 45 years, with internal soft tissue injury being a relatively infrequent but serious outcome. Frequency incidence rate being about 1 to 1.2% of all trauma cases. Unlike solid organ injuries, the soft tissue injuries often present with subtle or non-specific symptoms such as dull pain, vomiting, fever, and shock, leading to delayed diagnosis and increased morbidity and mortality. Early identification is crucial as delays can result in peritonitis, hemodynamic instability, and poor outcomes. While DPL and FAST have limited sensitivity, especially for retroperitoneal injuries, CT scan offers a superior diagnostic accuracy by identifying the source of hemorrhage or delineating the organ-specific damage with high precision. The aims and objectives of the study are to evaluate the imaging findings in patients with blunt trauma, emphasizing the variability in presentation and the diagnostic role of CT, and also to emphasize the importance of early CCT evaluation in improving patient outcomes and reducing morbidity and mortality. The methodology, The case approach towards the study is of a retrospective case series conducted in the Department of Radiodiagnosis in KIMS of Bhubaneswar, which included 12 patients presenting with a history of blunt trauma. All patients underwent detailed clinical evaluation followed by CCT of the abdomen and thorax for assessment of internal organ injuries. The technique used is CCT study were conducted using a 64-slice GE Optima CT660 with 1.25 slice thickness, and contrast agent used was iobromide ultraviolet. Coming to the first case is of a 42-year-old male with alleged history of road traffic accident, following which he sustained injury to right leg and abdominal pain in the left hypochondriac region with nausea and vomiting, which were progressive in nature and later developed reduction in blood pressure. Examination findings showed multiple abrasions and contusions over the abdomen and left hypochondriac regions. On plain NCCT abdomen scanning, we can see multiple hyperdense calculi in the GB lumen and in the extraluminal pericholecystic region. On contrast imaging, we can see in the portovenous phase that there is a defect which was noted in the anterior wall of the GB. On further sectioning, we can also see that the hyperdense calculi were noted in the pelvis and in the dependent portion associated with the ascitic fluid. And in the also, the hyperdense calculi was seen in the perihepatic region. The patient was managed conservatively and discharged with hemodynamic stability. Case 2 is of a 26-year-old female, came with chief complaints of abdominal and chest pain since last 4 days with alleged history of RTA. There was associated with shortness of breath and no history of loss of consciousness, vomiting or seizures. On examination, multiple abrasions and lacerations were over the chest and bilateral upper limbs were noted. Axial CT sectioning shows diffuse omentomesenteric fat stranding with areas of collection, suggestive of mesenteric laceration. On further sectioning, we can also see that there is internal air foci suggestive of pneumoperitoneum in the patient. Sagittal sectioning shows a long segment hypoenhancement and perforation of the proximal to distal ileal loops as seen. And further sectioning, we can also see that there is some ill-defined heterogeneous hyperdense content with surrounding fat stranding in the mesentery, suggestive of mesenteric hematoma. And we can also see that there is a heterogeneous enhancement pattern in the left renal parenchyma suggestive of contusion. Patient was taken for emergency exploratory laparotomy and the findings were consistent with a gangrenous ileum with approximately 5 liters of fecal peritoneal fluid matter. Patient was conserved with ileostomy and colostomy, a double barrel stoma with the intraoperative finding of the gangrenous ileal loop seen. The third case is of a 35-year-old male with complaints of diffuse pain of the abdomen and chest region with alleged history of RTA with blunt trauma to the abdomen and difficulty in breathing. Axial CT sectioning, we can see that there is a bulky right adrenal gland. On further sectioning, we can also see that there is presence of fluid in the abdominal cavity with relative hyperdense dependent content suggestive of hemoperitoneum. On further examining, we can see that the focal hyperdensity in the right adrenal gland with a CTHU value of 50 to 60 in the body of the right adrenal gland, showing no enhancement on post-contrast studies, which was consistent with the features of adrenal hematoma. On further evaluation, the patient was managed conservatively and on supportive medication and treatment. Case 4 is of a 60-year-old male with complaints of pain in left shoulder and left-sided chest pain with alleged history of RTA 1 day back, associated shortness of breath and head injury. Axial CT sectioning on bone window where we can see that there is a displaced fracture of the left, third and fourth rib. On CCT sectioning where the presence of air fluid level is noted in the lung parenchyma, which were consistent with the features of post-traumatic pneumatocele. On lung windowing imaging, we can see that there is a surrounding consolidation of the lung parenchyma with mild GGOs, which were in favor of lung contusion. The patient was managed conservatively and on supportive treatment and medication. Case 5 is a 36-year-old male present with casualty in intubated state with dilated pupils and positive EFAST findings. Examination revealed multiple abrasions all over the abdomen, and EFAST came to be positive with perihepatic collection. Axial CTC sectioning shows a linear non-enhancing laceration in the pancreatic parenchyma with another similar laceration in the body region of the pancreas. Sectioning also showed a hypodense collection.
Quickly, time.
In the laceration and minimal ascites in the pericholecystic region, with sagittal sectioning shows a through and through laceration of the abdomen. Patient was managed conservatively, but the patient developed cardiac asystole, and despite all measures, patient could not be resuscitated and declared dead. Case 6 is of a 12-year-old male. Casualty complains of multiple episodes of vomiting of coffee color with road traffic accident history. you can see that there is a defect in the anterior wall of D3 segment of duodenum with surrounding cholecystic collection and air foci in the abdomen. Intraoperative finding shows a gangrenous mesentery with perforation noted in the lateral, just lateral to the DJ flexure. Patient was taken for emergency exploratory laparotomy and done with duodenojejunectomy, and feeding jejunostomy was done. These are the results with the injured organs and the outcome for the patient, where management was done either surgical or conservative way. By contrast, CCT plays a crucial role in early diagnosis and management of soft tissue injuries, enabling timely surgical intervention and improving outcomes. Remains most reliable non-invasive tool for evaluating soft tissue injuries in blunt trauma. It plays a pivotal role in evaluation, offering rapid, accurate assessment of internal injuries, helps in early detection of soft tissue injuries, localization of active bleeding, and grading injury severity, crucial for guiding management decisions. These are my references. Thank you.
Okay. Next.
Thank you, Dr. Atharv. Now we have Dr. Bharat K, whose topic is a comparative analysis of mammography, ultrasonography, and shear wave elastography features in correlation with breast cancer, molecular subtypes, and prognostic markers.
My presentation is about comparative analysis of mammography, ultrasonography, and stereoelastography, features in correlation with breast cancer molecular subtypes and prognostic markers. Breast cancer is a heterogeneous disease classified into various molecular subtypes, and biopsy is a gold standard for its diagnosis and further management. However, non-invasive modalities like mammography, B-mode ultrasound elastography, and stereoelastography offer potential to predict subtypes pre-biopsy by correlating imaging features and biomechanical properties with underlying tumor biology. Our aims and objectives are to evaluate and compare the diagnostic performance of mammography, B-mode ultrasound, and quantitative stereoelastography in predicting molecular subtypes of breast cancer. And secondary objectives included are correlating specific imaging features with subtypes and assessing the ability of stereoelastography to differentiate between aggressive and non-aggressive subtypes. Study setting, design and setting is prospective observational study done in AIIMS Bhubaneswar, and we included all the patients of BIRATS 4, 5 and 6 category lesions above 30 years of age, and we excluded benign lesions and suspected recurrence patient, and if patient has taken prior neoadjuvant chemotherapy, or if patient refuses a scan. In our study, we included 110 patients, and all patients have undergone mammography, ultrasound, stereoelastography, and biopsy, and diagnostic performance was assessed using sensitivity, specificity, positive predictive value, negative predictive value, and we also did association between categorical imaging features and subtypes using Pearson chi-square test. And quantitative stiffness data from stereoelastography was compared between aggressive and non-aggressive subtypes and across the subtypes using Mann-Whitney's U-test and Krusal-Wallis H test. And this was our acquisition protocol. We did craniocaudal medial lateral oblique views in mammography, and for ultrasound we followed routine guidance of B-mode ultrasound. And for elastography, we took 3 ROS from the hardest part of the lesion, and the machine will automatically give the average and median of the lesion in stiffness. In results, the mean age of the patients in our study was 52 years, and luminal A subtype was more prevalent, followed by luminal B, TNBC, and HER2 enriched. This graph depicts the histological grades across the molecular subtypes. This shows that grade 3, more predominance of grade 3 tumors in TNBC and HER2 enriched groups. And regarding association of mammographic features and molecular subtypes, this graph demonstrates that luminal A and HER2 enriched subtypes more commonly demonstrate irregular shape, while round and oval oval shape is more frequent in TNBC, and speculated margins were more common in luminal A and B, whereas microlobulated and circumscribed margins were more common in TNBC. Uh, in our study, there was no significant association between calcification, architectural distortion with molecular subtypes. Uh, in sonographic features, nearly all luminal B and HER2 enriched lesions are irregular in shape, and a higher proportion of TNBC showed round and oval shape, and speculated margins were predominant in luminal subtypes, and microlobulated and other margins were more common in TNBC. Posterior acoustic features were more frequently associated with luminal A, but it does not reach the threshold of significance, and it doesn't vary significantly among subtypes. And there was higher sonographic node positivity seen in luminal B and HER2 enriched groups, which indicate more aggressive nature. And we also compared the mean elastographic stiffness across the molecular subtypes and between the aggressive and non-aggressive groups. HER2 enriched and TNBC subtypes exhibited significantly higher sonographic stiffness than luminal subtypes, and this elastography stiffness correlates positively with the tumor aggressiveness, providing potential non-invasive biomarker for molecular subtype differentiation and prognostic stratification. This was a graph indicating the same, and we overall pattern mammography is more sensitive but less specific for luminal subtypes, and more specific but less sensitive for aggressive subtypes. In our study, B mode offered better superior sensitivity and accuracy compared to mammography, particularly luminal for differentiating luminal and TNBC. I kept some examples of some atypical cases. Here we can see irregular shaped mass and margins were speculated. However, biopsy came out to be TNBC, and on elastography, it confirmed the aggressiveness of the lesion, which was around 164 kPa. TNBC itself is a heterogeneous disease which has many subtypes within the TNBC, which can present as various variable
forward.
imaging features. And this is another example of TNBC appearing as well-defined round circumscribed mass with higher elastography values. And another case showing irregular mass with partially obscured margins, and ultrasound microlobulated angular margin, and biopsy removed luminal A. In conclusion, a multimodality imaging approach enhances non-invasive prediction of breast cancer molecular subtypes, and B-mode ultrasound is the most accurate single modality, particularly for identifying luminal and TNBC subtypes. Quantitative stereoelastography provides a valuable independent measure of biological aggressiveness, and overall key findings indicate that no single modality is uniformly superior for predicting the molecular subtypes. Rather, they offer a complementary diagnostic information. And by combining both morphological data from mammo and USG and quantitative data from elastography, we can significantly improve pre-biopsy risk stratification and aid further management. And these were my references for study used.
So, can it be correlated with Byret's classification, molecular? You have thrown light on molecular.
Molecular classification, ma'am. These luminal subtypes, like if imaging features are like directing towards that subtype
Yes.
based on this elastrophy and mammography.
You have not correlated with Byret's classification?
Byret's classification.
Yes. So, we are giving nowadays.
Like how many Byret's for or
Yes.
luminal?
Yes.
We did not do that.
Acha,
We'll
okay.
do.
Okay. Thank you.
Thank you, Dr. Bharat. I would like to inform all the delegates that we are pressing the buzzer twice. Once it is at 5 minutes and once it is at 6 minutes. And I would like to request all the delegates to keep their presentation within the time limit of 6 minutes.
Good morning, everyone. So my paper topic is contrast enhanced MRI in association with histopathological correlation for characterization of soft tissue tumors of extremities. Soft tissue is primarily a mesenchymal derivative and comprises of skeletal muscle, fat, fibrous tissue, peripheral nervous system, and the serving vascular structures. All soft tissue masses should be approached with the awareness that they may represent a sarcoma. Physical examination may provide some clues that suggest malignancy, but none are pathognomic. Failure to recognize these features at initial assessment can lead to misdiagnosis and interventions that may compromise survival or limb salvage opportunities once the correct diagnosis is made. Before the availability of MRI, physicians usually relied on patient history, physical examination, and conventional radiographs and CT for decision making. However, MR imaging is the preferred modality for evaluating soft tissue lesion. It provides superior soft tissue contrast, allowing multiplanar image acquisition, obviates the needs for identic contrast region and for ionizing radiations. So according to WHO classification of soft tissue tumors 2020, this is a vast classification which includes more than 100 plus tumors, but the broad category is usually divided into calcification, necrosis, and adipocytic tumors containing fat, and according to the intense enhancement. Aim and objective of this is to evaluate the role of contrast enhanced MRI in phenotypic characterization of soft tissue tumors and correlate with pathological findings and accessing its sensitivity, specificity, accuracy, positive predictive and negative predictive value, and also to differentiating benign versus malignant lesions. So total patients was 50, and it was done over a duration of 18 months in 3 Tesla MRI. Inclusion criteria is usually patient presented with extraosseous lump in extremities, and the total out of 50, the male was 34 and the female came out 16. So in observation and results, the first bar graph shows the mean age. The mean age was around 41 years. The most common age of presentation is around 20 to 40 years. And the most common size, which was more than 5 centimeter, which usually correlates with the malignant lesions. And the most common site in extremities is the right lower limb, followed by the right upper limb. And on the right lower limb, the most common site came out to be thigh, followed by the forearm. In the MR signal characteristics, out of many variables which I took, the most common one was T1 signal intensity, in that it is either homogeneous or heterogeneous, or it can be hypo, iso, or hyper. So in T1, most common the lesion shows homogeneity, and which usually correlates with the benign component and having more than 70% sensitivity. In T1 either it can be hyper or hypo. The most common lesion was usually benign, and it shows hypointense. Out of T2 signal intensity, the most common heterogeneity signal shows by benign malignant lesion out of mostly 100%, and the most common tumors are usually T2 hyperintense, and it correlates with usually malignancy. In DWI, around 100%, nearly 100% of lesion shows diffusion restriction, while benign lesion usually has no diffusion restriction. And post-contrast enhancement, the more the heterogeneity, the more malignant is the lesion. Nearly 100% shows the malignant correlation. Other than this, many more such as STIR and spectroscopy was also be used. And in MR phenotype, this is the pie chart showing the broad category of the lesion which came. This is the MR phenotype showing benign, and this one is the malignant one. And according to the histopathological correlation, this is the pie chart showing the benign category, and this one is the malignant one, the right lower one. This is the first case showing the plantar surface showing ill-defined heterogeneously lobulated T1 hypointense, iso to mild hypointense lesions, T2 showing hyperintense lesions, intermediate to mild hyperintense lesion with significant post-contrast enhancement. In histopathology, it came out to be synovial sarcoma. It was given as synovial sarcoma also. In histopath, it came out same. The next was the image shows a well-defined lesion in the intramuscular compartment showing T1 significant hypointense and T2 star hyperintensity, and post contrast it shows full hyperintense increase contrast enhancement with no evidence of any neurovascular bundle involvement. In histopathologically, we can see there is hypercellular Antony A lesions, Antony A and hypocellular Antony B areas with intervening myxoid areas. It was given as an myxoid schwannoma and it came out the same. So according to my study, the MR sensitivity has an 89.6% sensitivity and specificity of 80%, accuracy of 86, and positive predictive value of 86% in characterizing soft tissue lesions as benign or malignant with a p-value of 0.001. According to the WHO category, these are the broad category, and out of this, the most common lesion which I got is benign 7% and malignant is also 7 tumors, so nearly most common is the nerve sheath tumors. So 50 patients were studied over a period of 18 months who were referred to MRI with suspected diagnosis or diagnosed soft tissue swelling involving extremities after obtaining their informed consent. MR findings are noted regarding the location, size, extensions, and pattern of appearance, and enhancement pattern and neurovascular bundles involvement, and lesions were diagnosed as benign, malignant, and suitable. 3 differential diagnoses was given for phenotypic characterization. Histopathological and immunohistochemistry was performed, and the sensitivity, specificity, positive and negative predictive value was assessed. So at last, right thigh is the most common site for soft tissue lesions among extremities. Lesion more than 5 centimeter and T2 heterogeneity has high sensitivity for malignancy but lacks specificity. Heterogeneous post-contrast enhancement, restricted diffusion shows statistically significant association with malignant regions. MRI is an excellent modality in imaging soft tissue tumors. It not only helps in delineating extent of the lesion but neurovascular bundle involvement, and also helps in arriving at reasonable differential diagnosis regarding phenotype of the lesion. It also helps in accessing treatment response post-chemo radiation. These are my references, and thank you.
Any cases that were thought to be benign in MRI and turned to be malignant in histopath or opposite direction?
One pregnant patient was there, so we did CT instead of MR, and it came out in malignant only.
No. I'm asking, MRI you gave as like benign, and in histopath it turned to be malignant.
Yes, sir.
Or MRI gave as malignant, or histopath turned to be benign. Are there any cases?
Yes, sir. MR we gave as a benign tumors, but it came out to be malignant. On I think 2 to 3 cases it came.
Okay.
Thank you, Dr. Vishesh. Next, I would like to call upon Dr. Gaurav Kumar.
Good morning, everyone. My paper on the evaluation of the pediatric neurological, craniofacial, and spinal abnormalities through CT. And the aim is to evaluate the diagnostic role of the CT in the diagnosis. Pediatric craniofacial and neurological and cervical spine abnormality often present with the overlapping clinical features and complex bony anatomy. And a retrospective observational study was conducted involving the 10 pediatric patients who came to hospital with suspected or confirmed rare craniofacial spinal neurological abnormalities included Crouzon syndrome, Down syndrome, achondroplasia, congenital nasal pyriform aperture stenosis, scaphocephaly, mineralizing microangiopathy. Coming to the first case, the Crouzon syndrome, a 13-month-old female presented with the progressive bilateral proptosis since birth and difficulty in the eyelid closure and with the episodes of the obstructive sleep apnea with insignificant family and the birth history. On examination, bilateral proptosis with hypertelorism, high arch palate, and hypoplastic maxilla as shown in the clinical images. On CT 3D reconstruction, revived coronal lambdoid squamous sutures resulting in an overall configuration that is the Turi brachycephaly, that is a tower shaped skull. Trigonocephaly is also noted, that is triangle shape of forehead due to the fusion of the metopic suture. Bilateral shallow orbit were also noted, along with the mid-phase hypoplasia, resulting in the relative mandible prognathism displayed by the white arrow. And cervical spine screening revealed partial broke vertebra at the few levels, and the multiple butterfly vertebrae also noted. In the post-operative, fronto-orbital advancement surgery was done, which result in the reduced exophthalmos and increased cephalic index with decreased vertical height of the forehead. Coming to the next case, a 10-year-old child admitted with a complaint of high-grade fever and recurrent seizure with progressive weakness in the limbs, leading to the inability to walk. The child also showed the global developmental delay. On examination, the child has a syndromic face with low set of ears and protruded tongue, slant eye, leg ophthalmos with exposure keratopathy. NCCT section revealed presence of dysplastic os odontodium with features of atlantoaxial instability and mild basilar invagination. Abnormal spinal curvature resulting in the compression of the spinal cord as evident from the MRI by T2 stare hyperintensity. On NCCT, the unfused hypoplastic and displaced posterior arch of C1 vertebra into the foramen magnum with atlantoaxial instability causing the significant narrowing of the upper cervical spinal canal and the craniovertebral junction. Coming to the next case, a 2-year-old male child brought with the failure to thrive and stunted growth. There was no perinatal complication, and developmental milestones were also appropriate for the age. On examination, there is a depressed nasal bridge, prominent forehead, and protruding eyeball, as shown in the clinical images. On NCCT, brain shows the skull base with crowding at the foramen magnum and caudal descent of the cerebellar tonsil. There is associated supratentorial ventricular dilatation also. And CT 3D reconstruction image shows frontal boozing, depressed nasal bridge, and copper-beaten morphology, which is a sign of intracranial hypertension. The NCCT also revealed the platybiasia with reduced clavus length and foramen magnum narrowing. J-sep sella is also noticed. Coming to the next case, a female infant presented with breathing difficulty immediately after birth. The child was shifted to NICU due to the respiratory distress, and on examination, there is an inability to pass the infant NG tube through the nasal cavity was noted. And NCCT revealed overgrowth of the nasal process of the maxilla and the medially angulated maxillary spines, shown by the yellow arrow, resulting in the narrowing of the piriform aperture, measuring 4 mm, shown by the red arrow. NCCT also shows the single median maxillary central incisor. This finding is associated with hollow prosencephaly, and thus the MRI was advised. But it was come out to be normal. Come to the next case, scaphocephaly. The 8-year-old boy presented with the elongated head shape, frontal boozing, and poor academic performance. The patient also had a history of delayed developmental milestones, and on the examination, the key finding was the macrocephaly and frontal boozing. On MRI, there is an increased AP diameter was noted, and further the CT was advised. On the 3D reconstruction, revealed sagittal suture fusion underlying the cause. Bilateral coronal suture rhamnoid are normal. Coming to the next, the 18-month-old female came to the Broadway left-sided weakness after the minor fall. And the child had a history of the birth asphyxia and the hypoxic ischemic encephalopathy. There decreased power in both the lower limb and deviation of the angle of heart toward the right side on examination. NCCT shows the linear and punctate calcification bilateral lenticular arteries and subacute infarct in the right lentiform nucleus corona radiata, which shows T2 filial hyperintense lesion, DWI mild diffusion restriction with pseudo-nobilization on the ADC, suggested acute to subacute infarct. With a normal MRI angiography, the final diagnosis was unspecified stroke, likely secondary to the mineralizing angiopathy, which is better appreciated on the NCCT. In result and discussion, the finding from the studies demonstrate that the NCCT with 3D reconstruction provides superior visualization of osseous abnormalities and calcification, established it as an essential modality for the accurate diagnosis, management of the complex periodic neurological, craniofacial, cervical spine disorders. These are my references. Thank you.
Okay, thank you. Next.
Thank you, Dr. Gaurav. Next, I would like to call upon Dr. Ishani Nair.
Next candidate, please stand there only nearby. Next, who is the presenter? You call them and make them stand there.
Good morning, everyone. The topic of my paper is When the Dura Thickens, Rethinking Hypertrophic Pachymeningitis. Introduction. Hypertrophic pachymeningitis is a disorder characterized by localized or diffuse thickening of the dura mater around the brain or spinal cord, manifesting with varied neurological symptoms depending on the site and extent of involvement. The etiology is diverse, including infectious, inflammatory, neoplastic, and idiopathic causes. Contrast-enhanced MRI is the investigation of choice, aiding in evaluation of disease extent, severity, and characteristic enhancement patterns essential for determining etiology and management. Aims and objectives: to evaluate the MRI characteristics of hypertrophic pachymeningitis and to identify the spectrum of underlying etiologies and imaging patterns aiding in its diagnosis and differentiation. Methodology: a retrospective descriptive study was conducted during a study period of 6 months in which 15 cases demonstrating enhancing dural thickening on MRI suggestive of hypertrophic pachymeningitis were taken for review of key radiological findings, clinical data, laboratory parameters, and histopathological findings were collected. Imaging protocol: all scans were done on 1.5 Tesla MRI machine, GE Healthcare. MRI imaging was carried out in both non-contrast and post-contrast phases with administration of 0.2 ml per kg IV of gadolinium with the pressure injector. These were the sequences that were taken. Case 1. 53-year-old male presented with headache and low-grade fever for 4 months. Irregular enhancing pachymeningeal thickening was noted along the posterior falx cerebri with peripherally enhancing plaque-like T2 hypointense lesions with surrounding vasogenic edema. Loss of flow void with partial recanalization was seen in superior sagittal sinus. Leptomeningeal enhancement was noted in bilateral parieto-occipital region. CSF analysis was done which revealed lymphocytic pleocytosis, elevated protein and ADA levels. Diagnosis of tubercular hypertrophic pachymeningitis was made and the patient was started on ATT. The Eiffel by night is a descriptive radiological sign described for hypertrophic pachymeningitis involving the posterior falx and tentorium cerebelli that shows enhancing peripheral zone of active inflammation with hypointense fibrotic center. Case 2. 39-year-old male presented with headache and vomiting for 1 month. Multiple T1, T2 hypointense lobulated enhancing plaque-like lesions were noted along the anterior and posterior falx cerebri and in right middle cranial fossa, causing mild perilesional edema and mass effect on adjacent brain parenchyma. CSF analysis showed mild lymphocytic pleocytosis, normal ADA levels and elevated ACE levels. Histopathology revealed non-cageating granulomas which showed positive reticulin stain and negative on ZN stain. Diagnosis of neurosarcoidosis was made and the patient was started on corticosteroids. Case 3, a 40-year-old female presented with left hemicranial headache for 6 months, decreased vision in left eye with restricted movement for 2 months. T1, T2 iso-intense enhancing plaque-like thickening was noted along the roof and lateral wall of left orbit and middle cranial fossa. The lesion is displacing the left lateral and superior recti with mild proptosis of the left eyeball. Asymmetrical expansion of left sphenoid bone showing heterogeneous enhancement was seen and CT showed hyperostosis. MRS showed reduced NAA, increased choline peak and presence of alanine peak suggestive of end-plaque meningioma. Tumor excision was done which came out to be atypical meningioma. Case 4, 48-year-old female, known case of triple negative invasive ductal carcinoma of breast, post-modified radical mastectomy and chemotherapy, presented with complaints of headache and bilateral lower limb pain for 5 days. Multiple heterogeneously enhancing nodular lesions were seen in bilateral cerebellar hemisphere and brainstem, showing surrounding edema and swan bluing. Irregular enhancing dural thickening was noted in bilateral frontoparietal lobes. Diagnosis of intraparenchymal hemorrhagic and pachymeningeal metastasis was made and the patient was started on whole brain radiotherapy. Case 5, right hemicranial headache for 6 months associated with vomiting. Focal smooth enhancing dural thickening was noted along the right temporal lobe and right tentorium cerebelli. MR angiography was normal. Investigations, CSF analysis was normal, ANCA negative, ESR was within normal limits, and IgG4 negative. Meningeal biopsy was done, which was inconclusive. A diagnosis of idiopathic hypertrophic meningitis was made, and the patient was started on corticosteroids. This is my master chart. Results. A total of 15 patients were included in the study. Meningitis was secondary to infectious etiology. In majority of the cases, predominantly TB, followed by neoplasm, inflammatory etiology, intracranial hypertension, and idiopathic causes. Thickening was diffuse in 26% cases and focal in 73% cases. Post-contrast imaging showed homogeneous and heterogeneous enhancement distribution as follows. Focal thickening predominated in tubercular and neoplastic cases, suggesting localized infiltrative pathology. Diffuse thickening was seen in inflammatory and intracranial hypertension, indicating systemic etiology. Irregular morphology was common in infectious and neoplastic causes, reflecting dural destruction and infiltration. Smooth morphology was seen in inflammatory cases and intracranial hypertension, indicating benign thickening. Etiology versus enhancement pattern. Heterogeneous enhancement predominated in tubercular and neoplastic cases. Homogeneous enhancement was seen in IgG4 related thickening, sarcoidosis, and intracranial hypertension, suggesting uniform dural involvement. MRI thus served as a strong non-invasive tool for differentiating causes of hypertrophic meningitis before biopsy. Discussion. The etiological classification of hypertrophic meningiopathy is as follows. Amongst the other causes, miscellaneous causes like Erdem-Chester disease, Rosai-Dorfman disease, and MPS is also noted. Discussion. This is the various pattern of dural thickening, diffuse dural thickening, and focal dural thickening as follows. Conclusion. Hypertrophic meningitis follows a chronic relapsing remitting pattern, and the patient is on long-term follow-up. While tissue biopsy remains the gold standard for definitive diagnosis, the study emphasizes the importance of MRI assessment for accurate diagnosis and effective management. Thank you.
Is biopsy done in all patients?
No, sir. In the CA breast case, the patient was taken for PET CT, and since thickening was seen, the patient was taken for radiotherapy. In the tubercular meningitis case, since CSF showed increased ADA levels and CT thorax changes as well, so the patient was started on ATT and improvement was noted.
Any relation with location or size of the thickening with pathologies?
Yes, sir. Sir, in IgG4 related cases and in neurosarcoidosis, the posterior cranial fossa is typically seen. In neurosarcoidosis, typically there is involvement of pituitary stalk and infundibulum, and this was.
Okay, thank you.
Thank you.
Thank you, Dr. Ishani. I would like to request all the delegates to kindly come sit up front so that it's easier for us to call you guys and the process can be a bit fast. So next is Dr. Keshav.
So good morning. My topic for today is the study of hepatic vein waveform and splenoportal index in correlation with Child-Pugh classification and esophageal varices in patient with CLD. CLD is a significant global health issue which been the 11th leading cause of death and 15th leading cause of morbidity. The major complication especially is the portal hypertension. This elevated pressure can lead to the formation of esophageal varices and dilated vein in the esophagus that are prone to rupture, causing severe life-threatening bleeding. Esophageal varices is common in cirrhosis, affecting 50% of patients. Therefore, although the upper gastrointestinal endoscopy is the gold standard for diagnosis and grading of varices, it is invasive procedure with risks such as sedation complication and gastrointestinal perforation. As a non-invasive alternative, the color Doppler has become an increasing valuable tool for evaluating portal hypertension, predicting the presence of esophageal varices, and the technique assess the hepatic venous waveform and the splenoportal index, which can indicate the severity of portal hypertension. Doppler ultrasound offers a safer and more cost-effective means for monitoring CLD, reducing the need of invasive procedures while providing reliable assessment for the management of liver disease and its complication. My aim is to evaluate different hepatic venous waveform and splenoportal index in patient of CLD and to evaluate their association with esophageal varices and Child-Pugh score. The objective is to study different types of hepatic venous waveform, to assess the splenoportal index, to evaluate the esophageal varices in patient of CLD, and to find their association of esophageal varices and Child-Pugh score with hepatic venous waveform and splenoportal index. The study design, a cross-sectional study, was conducted in Department of SUM, including 50 subjects. The study group, patients with CLD was diagnosed either by clinical, radiological, or histopathological examination, and the duration was about 6 months. The inclusion criteria, patient diagnosed with CLD, duration of more than 6 months, patient should be above 18 years, and both old as well as newly diagnosed cases were included. But the exclusion criteria were the patients who have already undergone therapeutic endoscopic procedures, or the patient who have portal vein, hepatic vein, or IVC thrombosis with post-splenectomy status, or hepatocellular carcinoma, or any heart or chest diseases, or patient who do not give consent. Methodology, the following data was collected from each patient: the relevant clinical history, the laboratory assessment, the LFT and coagulation profile, and the imaging evaluation by grayscale and color Doppler ultrasound using a GE Evolution S8 and GE Evolution E8 color Doppler system with a lower frequency curvilinear probe. Parameters were assessed: the liver size and ecotexture, as well as nodularity, presence of ascites, portal vein, the direction of blood flow, and the size of the porta. The hepatic vein assessment, whether it is the different types of waveform from triphasic to monophasic. Then the spleen, the maximum transverse diameter and the longitudinal diameters are included. We need to calculate the splenoportal index and the calculation of Child-Pugh score, the upper GI endoscopy and grading of esophageal varices. Case number 1, where the Child-Pugh score B was given with a 52-year-old male, for history of alcoholics in 15 years, and there was abdominal distension, pedal edema since 2 months, and the blood parameters were given. The Doppler findings, which were SPI, the value came out to be 5.5, and the hepatic vein waveform was biphasic. The esophageal varices was grade 2. So the interpretation was the moderate portal hypertension with altered hepatic compliance. The splenoportal index and waveforms were finding consistent with Child-Pugh B. Another case, which was advanced disease like Child-Pugh C, was given. In this, the Doppler parameters were the splenoportal index, which came out to be 8.6, and the grade 3 endoscopy esophageal varices was given, and the hepatic venous waveform was monophasic. Another case, here the Child-Pugh score A was given, and our Doppler parameters were the splenoportal index, which was 2.7, hepatic vein waveform was triphasic, and esophageal varices was absent. So it was preserved hepatic compliance and no significant portal hypertension consistent with Child-Pugh A. The result, a total of 50 patients were taken of the age between 35 to 70. According to the Child-Pugh classification, Child-Pugh A was 15 patient, B was 20, and C was 15 patient. In this data, we can see is the mean portal vein velocity. As the Child-Pugh score increases, the value keeps on decreasing, so it is inversely proportional. And the mean splenoportal index value has increased from 3.2 to 8.3. And the predominant hepatic venous waveform has changed from triphasic to monophasic waveform. The conclusion was the hepatic vein waveform and splenoportal index are simple and non-invasive and reliable Doppler parameters. They correlate significantly with Child-Pugh class and varicose presence. Doppler ultrasound can thus screen CLD patients for significant portal hypertension. These are my references. Thank you.
Thank you. Next.
Thank you, Dr. Keshav. Next, I would like to call upon Dr. Mitali Garg.
Good morning, everyone. My topic is diagnostic validity of CEST-MR imaging in characterization of glioma grades. Gliomas are common primary brain tumors and are classified on the basis of as low-grade and high-grade. The low-grade tumors, the earlier classification was 2016 classification, which was based on histology and tumor grading. However, in the 2021 classification, it is based on IDH mutation and 1p19q co-deletion. So according to that, if IDH mutation along with 1p19q co-deletion is present, it is an oligodendroglioma, which can either be a grade 2 or a grade 3 tumor, depending on the mitosis and proliferation. And if not, it is an astrocytoma, which can either be a grade 2, 3, or a 4 grade tumor. If IDH mutation is absent, that is IDH wild type, Then glioblastoma, it is called glioblastoma, which is a grade 4 tumor. Accurate characterization of glioma grades is crucial for guiding treatment decisions and predicting patient outcomes. CEST, or chemical exchange saturation transfer sequence, is an MRI sequence which is non-ionizing and non-invasive technique that provides insights into tissue metabolism and composition. The objectives of this study was to evaluate the diagnostic accuracy of CEST sequence in differentiating glioma grades and correlating with histopathological markers. Conventional structural MRI does not deliver the information on tumor genotype and is usually limited to the delineation of the diffuse gliomas. How the CEST sequence works is that the MRI sends a saturation radio frequency pulse that is targeted for the amide protons within the proteins. This saturated amide proteins exchange with the water protons, which results in a loss of signal of the water signal. So this drop-in signal is measured by the MR machine at MTR asymmetry value of 3.5 ppm, which is basically reflecting the amide proton transfer signal. So if a tumor is highly proliferative and has more protein content, it will have a high MTR asymmetric value. We assessed 30 patients on a 3 Tesla MRI scanner. With the conventional MRI protocol, we also added 2D CEST sequence and 3D CEST sequence. And histopathological evaluation was done according to the 2021 WHO classification, which included Ki67 labeling index, IDH mutations, and 1pQ19 co-deletion as well. Imaging and statistical analysis was done using a software which had a dedicated plugin for MTR asymmetry value calculation. This MTR asymmetry value was calculated on 2D, 3D, and 3D max CEST sequences, and a correlation was created between this and the Ki67 labeling index, which is a cell proliferation marker in histopathology. These values were then compared between the low-grade gliomas and high-grade gliomas. A heat map was used to represent the CEST effect on the images. So blue color would suggest a low or no CEST effect, which will correspond to a MTR asymmetry value of less than 1%. And similarly, a bright red color would represent a very strong signal and a hotspot of proliferative activity, which would suggest MTR asymmetry value of more than 4 to 5%. In this case, there was a case of 44-year-old male patient who presented with seizures. In imaging, there was a left frontal lobe lesion, and on CEST map, we can see that the green area is corresponding to a mid-value, moderate signal of CEST imaging, and which was MTR asymmetry about 2 to 3%. And on histopathology, this was a oligodendroglioma, WHO grade 3. Another patient, 62-year-old male patient, presented with vomiting and headache. On imaging, there was a left parasagittal frontal lobe lesion. On CEST map, we can see that the activity is around orange on the heat map, which was suggestive of a high-grade glioma. So on histopathology, this was a astrocytoma, CNS WHO grade 4. 49-year-old female patient presented with seizures, and on histopathology, it was given as glioblastoma. And on the CEST map also, we can see that the activity was in the red area, which was a very high activity of proliferation. So it was, in results, we can correlate that the MTR asymmetry value is moderately related to the tumor proliferation. Higher the MTR asymmetry value tends to occur in tumors with high proliferation rate, that is high Ki67 values, in all three sequences, that is 2D, 3D, as well as 3D max. Similar findings were seen as low-grade gliomas have a MTR asymmetry range of 2 to 3%, whereas high-grade gliomas have a range of 3 to 5%. Especially with the 3D max method, which highlights the most active areas of the tumor. Limitations of our results were that the sample size was quite small, and the data was taken on a 3 Tesla machine, and higher fields might change the sensitivity of the results. In conclusion, these findings show that 3D CEST imaging is a practical addition to the conventional 2D imaging and is valuable technique for glioma grading, diagnosis, treatment planning, and prognostication. It is also useful in identifying the most aggressive part of the tumor, so the surgeons can know which part to target during the biopsy and also plan the maximal safe resection of the most malignant part of the tumor, as they are most highlighted in the 3D CEST hotspot areas. Further, it can also help in monitoring of the treatment response. After therapy, the tumors may still show high CEST signal, whereas tumor-related necrosis, that is radiation necrosis, usually shows a lower signal. So it can help in distinguishing recurrence versus radiation necrosis. CEST imaging holds promise and is ultimately leading to improved patient outcomes and quality of life. These are my references. Thank you.
Thank you. Good.
We are done with the first 10 presenters. So next is Dr. Ojas Raghavendra Deshpande.
Not present? Absent?
Absent.
Good morning, respected judges, teachers, and my dear friends. The name of my topic is Development of a Simplified MRI Scoring System for Preoperative Differentiation of Xanthogranulomatous cholecystitis versus wall thickening type of gallbladder carcinoma. This was done under the guidance of Dr. Adyakinkar Panda, professor at IMS and Some Hospital. Xanthogranulomatous cholecystitis is a benign chronic inflammatory condition of the gallbladder which has a lot of imaging overlap features with gallbladder carcinoma. This makes preoperative differentiation very challenging because XGC requires simple cholecystectomy, whereas GBC demands radical surgery and lymphadenectomy. This calls for a structured MRI-based scoring system to improve diagnostic confidence and surgical planning. My primary objective would be to develop and apply a simplified, non-weighted MRI-based scoring system using 7 reproducible imaging features to differentiate XGC from GBC preoperatively. And my most important secondary objective would be to encourage standardization of MRI reporting terminology for gallbladder wall thickening lesions. This was a retrospective observational study of 20 histopathologically proven patients, which was also my most important inclusion criteria. 10 were XGC and 10 were GBC. My most important exclusion criteria was that lesions presenting as mass-forming GBC were not included. Only the wall thickening type was included. All MRI examinations were performed on a 3 Tesla United imaging scanner using a phased array body coil. Prior to applying the scoring system, the same MRI studies were independently reviewed by 2 radiologists of same certification and experience, both being blinded to clinical details and histopathology. Each reviewer made a visual assessment and categorized each case as XGC or GBC based on overall impression, no structured criteria. Diagnostic performance from visual assessment was later compared with the 7-feature scoring system. These are the 7 features that I have used, and every single one of the features has some or the other pathological basis in the disease process of XGC. Wall thickening pattern, mucosal continuity, mucosal retraction, intramural nodules, gallstones, diffusion restriction, and enhancement pattern. I have given 1 score to each one of these 7 features, thereby bringing my total score to 0 to 7. Any score of more than or equal to 4 would suggest XGC, less than or equal to 3 would suggest GBC. Let me demonstrate. These are the MRI findings of xanthogranulomatous cholecystitis in an 81-year-old female. As you can see, there is diffuse gallbladder wall thickening and T2 intramural hyperintense nodules on T2 weighted. You can see that the mucosal continuity is preserved. There is no diffusion restriction on the ADC map, and on delayed phase of dynamic contrast study, you can see there is heterogeneous and thickened gallbladder wall. Slotting all of these into my criterion, you get a score of 5, which says XGC is more likely. This was a similarly confusing case of wall thickening type of gallbladder cancer in an 80-year-old female. This shows mucosal retraction, and in fact, it also shows T2 intramural hyperintense nodules. However, there is marked diffusion restriction on the ADC map, and in spite of it showing delayed contrast enhancement, the contrast is heterogeneous and patchy. Slotting all of these features into my table, you get a score of 3, which suggested GBC to be more likely. These were the enhancement patterns that I chose. Type 1 was heterogeneous and thick. Type 2 was enhancing thick inner layer and mildly enhancing thin outer layer, which supported gallbladder CA. Results. 20 histopathologically proven cases were included. A simple 7-feature non-weighted MRI scoring system was applied. A score of more than or equal to 4 suggested XGC, improving preoperative diagnostic confidence and helping avoid unnecessary radical surgery. This is my first table. This is my entire data set, and as you can see, all 7 features were statistically significant, with wall thickening pattern, mucosal continuity, and intramural nodules being the most statistically significant. This is the diagnostic performance of the visual assessment versus the scoring system. As you can see, the scoring system demonstrated higher diagnostic performance and reduced inter-observer variability. This is the ROC comparison. The 7-feature scoring system showed a higher AUC of 0.95. In simple words, the scoring system is more consistent, more reliable, and reduces subjective variation compared to routine visual interpretation. Conclusion. future scope and the way forward. To the best of our knowledge, there is only one published paper proposing a structured MRI-based scoring method for this differentiation. This necessitates larger multi-center studies that are needed to validate and refine the scoring system. Our study has immense AI integration potential. The 7 imaging features can serve as training parameters for MLMs. AI can assist in automated measurement of wall thickness and the other 6 features. With continued validation, this system could evolve into a decision support tool that generates a possibility score for XGC versus GBC directly on the MRI workstation. This may significantly improve reporting efficiency, especially in high-volume clinical settings. And most important of them all, this scoring criteria can be incorporated into our day-to-day structured MRI reporting templates, promoting consistency and clear communication in radiology reports. These are my references. Thank you.
What was your sample size?
Ma'am, the sample size was 20.
With 20 only patients, you could validate that this is, and there is not only one paper, there are multiple papers.
Yes, ma'am.
You have written only one paper.
Ma'am, regarding the scoring criteria, there was one. However, there
scoring means a number you want to say?
No, ma'am.
Or structured?
Sorry, ma'am?
You told, just go to the previous slide. Only one published paper proposing a structured MRI based. There are a lot of papers. Okay?
Okay, ma'am.
You go through them. Okay.
Thank you.
Thank you, Dr. Rogers. Next, we have Dr. Mayank Bhatia.
Good morning, everyone. My topic is evaluation of the early cartilage degeneration in young adults with mild knee symptoms using quantitative T2 mapping. So articular cartilage is important as it ensures smooth and frictionless joint movement. Early degeneration in the articular cartilage starts with collagen disruption and increased water content. Routine MRI appears normal in early cases. So T2 mapping helps in quantification of the cartilage health by measuring the T2 relaxation time. Elevated T2 values indicate early degeneration and meaning early collagen disorganization and dehydration changes. Detecting such changes in the young adults with mild symptoms helps in early intervention and preventing osteoarthritis progression. So my primary aim was to evaluate the early biochemical cartilage degeneration by using quantitative T2 mapping, and my secondary objective was to compare the T2 mapping values between the symptomatic and the asymptomatic. And the second was to identify the regional variation in cartilage degeneration, medial versus lateral, and femoral versus tibial. Materials and method used. A cross-sectional study was conducted at departments of radiodiagnosis, IMS, and some hospital, and it includes 20 subjects, 14 were the cases, and 6 were the controls. Duration of study was for 6 months, and study population were young adults in the age of 18 to 45 years with mild knee symptoms. Inclusion criteria for the cases were age between 18 to 45 years, mild knee pain for more than 4 weeks, and no morphologic cartilage abnormality on routine MRI. Exclusion criteria for cases were previous knee surgery or a history of fracture, clinical ligament tear, or severe OA, or inflammatory arthritis. Imaging protocol which was used was, it was done on a 3 Tesla MRI scanner using a dedicated knee coil. Sequences which were taken was T1 weighted SAG, PD fat SAG, axial coronal SAG, T2 weighted axial coronal SAG, GRE SAG, and our main sequence T2 mapping, which was done in sagittal and axial. Reference T2 mapping value were if the color was blue color, then it suggests normal cartilage, and the value will be between 30 to 45. If the color is green, it suggests early degeneration. If the color on the map is yellow to orange, it suggests moderate degeneration. And if the color is red, it suggests advanced degeneration, and the value will be more than 65. T2 mapping valuation, quantitative T2 map were automatically generated by the scanner software. ROI were manually placed on the articular cartilage of medial femoral condyle, lateral femoral condyle, medial tibial plateau, lateral tibial plateau, and patellar cartilage. So this is a T2 map, and by side there is a T2 weighted SAG also. So ROI was placed like this, and most of the cartilage was blue color. That suggests that it is normal cartilage, and some green part can be you can see on the articular cartilage that suggests that there is early degeneration. This was done in 18 years old female, and this another study was done in 42 years old female, and this is how ROA was placed. and it showed more green color in articular cartilage than the previous case, so more degeneration was seen here. So this was the result which I got. Cases showed higher T2 values than the controls, be it any compartment. And the second thing which I saw was medial femoral condyle and patella showed more significantly increased. Summary of findings, all the compartments including patella showed higher mean T2 values in symptomatic knees. Medial femoral condyle and the patella demonstrated most significant increase. And color-coded map, generally control showed blue color, that is normal. And in cases, some green color and yellow color was seen, that means early degeneration. Discussion, quantitative T2 map successfully detected early biochemical cartilage changes if the young adults with mild symptoms and symptomatic knees showed significant higher T2 values compared to the controls, even when the conventional MRI appears normal. The patella and the medial femoral condyle were the most commonly affected sites. It is consistent with the early load-bearing degeneration pattern. And increased T2 values reflect collagen matrix disconization and increased water content, correlating with the early cartilage softening. Conclusion, quantitative T2 mapping is a sensitive and non-invasive biomarker for detecting early cartilage degeneration. T2 mapping detects the biochemical cartilage damage before it becomes structural, enabling the prevention rather than just the diagnosis. This is my reference, and thank you.
Thank you, Dr. Mayank. Next is Dr. Soumya Gupta.
Good morning, everyone. My topic is MRI pattern in mitochondrial encephalopathy. Mitochondrial encephalopathies are caused by mutation leading to defective oxidative phosphorylation, and brain is highly vulnerable due to high energy demand. Aim is to highlight MRI finding aiding diagnosis of mitochondrial encephalopathy and to correlate imaging finding with clinical and genetic data. It is a retrospective study of 10 proven cases of mitochondrial disorders. So case 1, leak syndrome, 14-month-old female patient presented with developmental regression, recurrent seizure episodes for 5 months. On clinical examination, patient has global developmental delay, head leg, reduced tone in all 4 limbs. Genetic test was positive for NARS2 gene, which is consistent with leak syndrome. On MRI, there were T2 flare hyperintensity in bilateral basal ganglia, predominantly in putamen region, showing subtle diffusion restriction, and MRS shows lactate peak. Based on these MRI findings, along with clinical findings, diagnosis of leak syndrome was made, which was confirmed by genetic testing. Case 2, MNGI, 29-year-old male patient presented with abdominal pain, diarrhea, vomiting, slurred speech, and progressive weight loss since 10 years. On clinical examination, patient has bilateral ptosis. Investigation showed elevated serum lactate, ammonia, and triglyceride level. Genetic test was positive for TYMP gene, which is consistent for MNGI. On MRI, there were diffuse confluent T2 flare hyperintensities involving bilateral cerebral hemisphere, sparing subcortical U fibers, with additional involvement of bilateral basal ganglia, thalami, brainstem, and cerebral peduncles along with cerebral white matter. So these findings, these are in favor of MNGI, and this was confirmed by genetic testing. Case 3, LBSL, 40-year-old female patient presented with progressive lower limb weakness with difficulty in walking since childhood with worsening symptom in last 1 year. Clinical examination had sensory ataxia, impaired proprioception, decreased vibration sense, bilateral foot drop. Lab investigation showed elevated lactate levels, and genetic test was positive for DARS2 gene. On MRI, there is involvement of periventricular white matter along with medullary pyramid showing diffusion restriction. Along with that, there is involvement of dorsal and anterolateral corticospinal tracts and spinal cord, and middle and inferior cerebral peduncles. On MRS, there is lactate peak noted in the area of affected white matter. So based on these MRI findings, along with lab investigation and clinical feature, LBSL was diagnosed, which was confirmed by genetic test. Case 4, Milas, 45-year-old female patient presented with sudden onset headache, vomiting, hearing loss, memory loss. And on investigation, there is mildly elevated serum lactate, which and on genetic, it is mutation in MTLT1 gene. So on MRI, there were multiple stroke-like lesions in the bilateral frontoparieto-occipital lobes and bilateral cerebellar hemisphere showing non-territorial asymmetrical distribution. MRA was normal with no evidence of arterial stenosis and occlusion, and MRS shows lactate peak in the affected area of cerebellum. So based on these MRI findings, MELAS was made and a diagnosis was made, which was confirmed by genetic test. Case 5 LH1 plus. So 24-year-old male patient presented with painless progressive bilateral vision loss with weakness of upper and lower limb. On clinical examination, patient has bilateral foot drop and diminished reflexes. Lab investigation shows mildly elevated serum ammonia, and genetic test was positive for ND4G. So on MRI, there was bilateral optic neuropathy as shown in figure 1 with altered signal intensity noted in periventricular white matter around the fourth ventricle, and also show diffuse cerebral and cerebellar atrophy. Sagittal T2 weighted image demonstrated short segment T2 flare hyperintensities in the spinal cord with the associated spinal atrophy. So based on these MRI findings and lab investigation, LH1 plus diagnosis was made. So this is my master chart containing 10 cases. Coming to results, so there are total 10 cases, out of which 2 cases are of leak syndrome showing basal ganglia involvement. 1 case is of MNGI showing diffuse confluent cerebral white matter involvement along with basal ganglia, thalami, brainstem and cerebellar white matter involvement. 1 case is of LBSL showing periventricular white matter, corticospinal tracts, medullary pyramids, cerebral peduncle involvement. Then 4 cases of MELAS comprising 40%. All of them showed non-territorial infarct involving cortical subcortical region of bilateral cerebral hemispheres, with 1 case showed involvement of bilateral cerebellar hemisphere. Then in LH1 spectrum, 1 case is of LH1 plus and 1 of LH1 comprising 20%. Both of them shows bilateral optic nerve atrophy, and LH1 plus also shows periventricular and cerebellar white matter involvement and spinal cord involvement. So MELAS is the most common mitochondrial encephalopathy comprising 40%, followed by leak and LH1 plus comprising 20% each, with LBSL and MNGI comprising 10%, and these are among the rare mitochondrial disorder. This prevalence pattern is similar to the reported cases and studies. MELAS and leak showed balanced gender distribution, and LH1 plus spectrum showed male predominance. This gender distribution pattern is consistent with existing literature. Lactate peak at 1.3 ppm was observed in 5 out of 10 cases. The peak was most frequently seen in MELAS patients, that is 75%, followed by leak syndrome, that is 50%, and 1 case of LBSL. These findings are similar to earlier studies where reported lactate peak on MRS was approximately 50 to 80% in mitochondrial disorders, and that too most commonly MELAS and leak. So this is my discussion here. So leak syndrome, there will be mutation in NARS2 gene, and MRI finding most common involvement will be basal ganglia, putamen region and brainstem. In MNGI, it was due to TYMP gene mutation, and MRI finding include evidence of leukoencephalopathy. Then LBSL, it is due to BARS2 gene mutation, and there will be long tracks involvement in brainstem and spinal cord. In MELAS, there will be non-territorial multiple infarcts involving cortical, subcortical region and basal ganglia calcification. LH1 plus shows optic nerve and optic chiasma involvement with multiple sclerosis like lesion in brain and spinal cord. Conclusion, MELAS is the most common mitochondrial encephalopathy with non-territorial asymmetrical stroke-like lesion. Leak syndrome is characterized by bilateral basal ganglia and brainstem involvement, and LH1 plus spectrum showed bilateral optic nerve and optic chiasma involvement. LBSL and MNGI are among the rare, which shows tract-specific involvement, and MNGI showed confluent white matter involvement. Thus, MRI with MRS plays important role in the diagnosis of diagnosis of mitochondrial encephalopathy. These are my references. Thank you.
Thank you, Dr. Soumya. Next is Dr. Pratik Pari.
Good morning, respected chairpersons, distinguished faculty, colleagues, and friends. It's a pleasure to present our study titled Utility of Computed Tomography for Comprehensive Evaluation of Severe Acute Pancreatitis Related Complications. This study was done at High-Tech Medical College and Hospital in Bhubaneswar and highlights how MDCT becomes the centerpiece in managing one of the most unpredictable abdominal emergencies. So, severe acute pancreatitis, that is when the modified CTSI enters 8 to 10 range, stops behaving like a simple inflammatory episode and begins to unfold as a disease of complications, each emerging in its own time. So, in the temporal evolution, we see in the early, we see organ failure dominating as physiology destabilizes. In the intermediate stage, we see collections maturing, necrosis organizing, and infections emerging. And in late stage, we see walled off necrosis, ductal disruptions, and vascular sequelae. So, MDCT remains the most reliable tool for early and panoramic assessment of severe acute pancreatitis and its downstream complications. The complication spectrum include vascular and non-vascular. Non-vascular have pancreatic and peripancreatic collections, necrosis, fistulae, duct disruptions, strictures, ascites, pleural effusion, bowel obstruction and ischemia, and splenic infarct. Vascular include pseudoaneurysm, rupture, hemoperitoneum, arterial and venous thrombosis, and portal hypertension. So, this was a prospective study conducted between November 2024 and October 2025 and included 40 patients who fulfilled strict criteria, that is clinically diagnosed severe acute pancreatitis with CT severity index between 8 and 10. We excluded patients who had renal dysfunction, contrast allergy, pregnancy, and those who did not consent. All scans were done in G revolution 32 slice MDCT following a pancreatic contrast enhanced protocol. Our philosophy was that CT should not be treated just as a mere scoring tool, but it should be treated as a decision-making blueprint guiding whether the patient requires conservative management, drainage, necrosectomy, or endovascular procedures. So, thus coming to results, we see a marked male predominance, that is 90%, mostly between the ages of 20 to 40, reflecting the demographic pattern of Eastern India. Now coming to the complications, here we see the acute necrotic collections being 90%, and the most common finding that is heterogeneous necrotic collections often extending beyond the pancreas and far more than what the clinical examination suggested. We also saw infected necrosis in 10% of cases having gas within the collections. And then we saw walled off necrosis, that is we saw both mature and early encapsulating collections. CT helped decided who needed drainage. Then we saw vascular complications in 20% of patients, including splenic and buccal venous thrombosis, splenic artery pseudoaneurysm, and including one large high-risk pseudoaneurysm case that we'll see later. In GI and biliary complications, we saw bowel edema, early ischemia, ileus obstruction, and sometimes also biliary compression. And then we saw pleural effusion in 85% of cases, predominantly on left side, but often bilateral. We also see ascites in 60% of patients. So let's coming to some to see some of the cases. So in case 1, we see the entire pancreas appears non-enhanced and is completely replaced by necrotic collections, accompanied by massive ascites and extensive solid necrotic deposits distributed throughout the peritoneal cavity. We also see bilateral pleural effusion more on the left side. In case 2, we see a peripancreatic collection at the tail showing early wall formation indicating evolving encapsulation. In case 3, we see acute necrotizing pancreatitis with presence of parenchymal gas in the body and tail of pancreas consistent with infected pancreatic necrosis. In case 4, we see acute necrotizing pancreatitis with non-opacification of rectopancreatic splenic vein, and in case 5, we see non-enhancement of head of pancreas with marked thickening of second part of duodenum. In case 6, we see acute necrotizing pancreatitis with a large aneurysm arising from splenic artery, which is partially thrombosed in its external part. Let's come into discussion. MDCT remains the cornerstone because it defines the true extent of the disease, detects life-threatening complications early, and also guides the entire step-up intervention strategy, whether to wait, to drain, to stent, to debride, or to embolize. It converts a highly unpredictable condition into a structured, actionable disease process. In conclusion, MDCT is indispensable in evaluating complications of severe acute pancreatitis. It provides comprehensive phase-wise assessment, quantifies disease burden, identifies vascular risks, and guides timely intervention, bringing clarity and direction to a rapidly evolving clinical emergency. These are my references. Thank you.
Thank you, Dr. Pratik. Next is Dr. Raksha.
Good morning, everyone. My topic is efficacy of clear cell likelihood score. Efficacy of clear cell likelihood score in distinguishing clear cell renal cell carcinoma from other renal masses. Renal cell carcinoma makes up nearly 90% of renal malignancies, and clear cell RCC is the most common and the most aggressive subtype. With increasing cross-sectional imaging, incidental renal masses are detected frequently. Clear cell early and accurate distinction between clear cell renal cell carcinoma and other renal masses such as papillary chromophobe oncocytoma or AML is critical to optimize patient management and to avoid over-treatment of benign lesions. CT and MRI can often be indeterminate, so many renal masses end up going for biopsy. But biopsy is invasive and 10 to 20% of them still turn out non-diagnostic. Because of this uncertainty, we need a standard reliable MRI tool. So my primary objective was to evaluate the diagnostic accuracy of clear cell likelihood score in predicting clear cell renal cell carcinoma using histopath as gold standard. The secondary objective was to identify which MRI parameters contribute most to the clear cell likelihood score performance. This was a cross-sectional analytical study conducted over 14 months, including 50 patients with solid renal masses. We excluded microscopic fat lesions and infiltrative diseases. In this study, we included patients of all age groups and sex, lesions with more than 25% solid enhancing components, and patients undergoing radiological evaluation for solid renal masses. We excluded masses with macroscopic fat, predominantly cystic lesions, lymphoma, and post-management patients. All patients underwent a multiparametric MRI on 1.5 Tesla or 3 Tesla scanners. Important sequences, we included T2 weighted imaging, in and out of phase imaging for microscopic fat, diffusion weighted imaging, and dynamic contrast enhancement with corticomedullary and delayed phases. Histopath was the gold standard. So clear cell likelihood score depends on 3 major features as T2 signal degree of corticomedullary enhancement and microscopic fat, and on ancillary features such as diffusion restriction, segmental enhancement inversion, and arterial to delayed enhancement ratio values. Score 4 and 5 strongly favors clear cell RCC. Score 1 and 2 usually indicate non-clear cell tumors. So in this case, we can see and this axial T2 weighted image show intermediate to high signal renal mass compared to the renal cortex. In axial and out of phase image, we can see there is signal loss in out of phase sequence. And in corticomedullary phase, there is mild enhancement. We assigned a score of CCLS4, that is likely clear cell, and on histopath, it came out to be clear cell carcinoma. In this second case, this axial T2 weighted image show a hypointense renal mass compared to the renal cortex, and axial T1 weighted corticomedullary phase show there is mild enhancement. In and out of phase images show there is no signal drop. We assigned a score of 3 and it came out as papillary RCC. In our study, 20 lesions were categorized as CCLS4 or 5. Out of these, 17 were true positive and 3 were false positives. Among 30 lesions classified as a score 1 to 3, 25 were true negative and 5 were false negative. This gave us a sensitivity of 77% and a specificity of 89% for predicting clear cell RCC. So our finding shows that CCLS serves as a reliable virtual biopsy. A high score 4 or 5 can confidently suggest clear cell renal cell carcinoma and help avoid unnecessary tissue biopsies and associated complications like bleeding, infection, and non-diagnostic sampling errors. It also improves reporting consistency between radiologists and integrates smoothly into routine renal MRI protocols. So it concludes CCLS is a practical, accurate, and reproducible scoring system for differentiating clear cell renal cell carcinoma from other renal masses. Its routine use improves diagnostic confidence and reduces unnecessary interventions. Thank you. These are my references.
Thank you, Dr. Raksha. Next, we have Dr. Rashi Arora.
Good morning, everyone. Today, I'll be presenting my PPT on evaluating the semi-quantitative hybrid MRI score as a screening tool in neurological manifestations of systemic lupus erythematosus. This study investigates a critical challenge that we all face in neuroradiology, that is, how to objectively quantify the burden of neuropsychiatric lupus. As we all are aware, systemic lupus erythematosus is a chronic systemic autoimmune and inflammatory disorder. But its neurological involvement, that is NPSLE, it's a diagnostic and a therapeutic nightmare. The clinical picture is ambiguous with 19 different neuropsychiatric syndromes. This is where the radiologist role comes in. MRI is the modality of choice, but its interpretation must be standardized to reflect clinical activity. Its prevalence varies widely from 37 to 95%. When we look at MRI findings, which are very diverse and common, which include white matter hyperintensities on flare sequence, infarcts and cerebral atrophy, and microhemorrhages on SWI and GRE sequences. The problem is there is no standardized, validated, and objective semi-quantitative MRI scoring system to correlate these findings with clinical disease activity index, that is the SLEDAI index. Coming on to the solution, the primary objective was to evaluate the diagnostic accuracy of this hybrid MRI score in detecting active neurological involvement using the gold standard SLEDAI index as the reference standard. The novelty is this is a score which will combine the objective measures, that is white matter hyperintensities, atrophy, and advanced sequences, including for microhemorrhages and contrast enhancement. So hypothesis was the semi-quantitative hybrid MRI score offers significant utility as a reproducible, non-invasive biomarker for neurological involvement in SLE patients. This hospital-based pilot cross-sectional diagnostic validity study was conducted at IMS and Some Hospital, Bhubaneswar, for a period of 12 months. We used a 3 Tesla protocol because of its higher signal-to-noise ratio, which is crucial for detecting subtle findings like microhemorrhages on SWI. CNS infections were ruled out with the help of lumbar puncture followed by CSF analysis. MRI was done within 72 hours of clinical evaluation using a 3T MRI scanner. The sequences included T1, T2, FLAIR, SWI, TOF, TWI, ADC, and post-contrast. For each subject, we documented their demographics, the clinical gold standard, that is the SLEDAI 2K score, full laboratory and immunological investigations, and crucially, the CSF analysis to exclude infection. Inclusion criteria includes children and adult patients fulfilling ACR, Euler 2K19 diagnostic criteria, and patients presenting with at least one neuropsychiatric manifestation fulfilling 1999 ACR and PSLE case definitions, and the patients who underwent brain MRI and SLEDAI within the same episode. CNS infections were ruled out with CSF study. Patients unable to undergo MRI and incomplete data were excluded. This is the SLEDAI, that is the clinical scoring system that we used as a reference standard. This is the core of our study, that is the hybrid MRI score. It is a semi-quantitative hybrid score, which includes 5 key MRI findings that have been implicated in NPSLE. Notice the white matter hyperintensities are the dominant feature, which range from 0 to 6, whereas infarct, cerebral atrophy, microhemorrhages were given scoring from 0 to 2, and contrast enhancement till 1. Total score comes out to be maximum 0 to 13. Now coming on to the cases, this is a 29-year-old female with a SLEDAI clinical activity score of 29. In this, we can look in axial T2 flare and T2 sequences, white matter hyperintensities, and a gliotic area in right frontal lobe. There was no contrast enhancement. According to atrophy, score was 1. Total score comes out to be 9. This is case of a 12-year-old female with SLEDAI score 26. In this, we can look out for white matter hyperintensities, diffuse cortical atrophy, and microhemorrhages in the cerebellar vermis region with hyperintensity in the vermis region. Total score comes out to be 6. This is another case of a 21-year-old female with SLEDAI score of 8. In this, we can look out for white matter hyperintensities and microhemorrhages in centrum semiovale. Score comes out to be 3. This is another case of a 48-year-old female with SLEDAI score 24. In this, we can look out for T1 hyperintense and T2 hypointense lesion with blooming on SWI and peripheral diffusion restriction. Likely early subacute bleed, hemorrhagic infarction was there, likely due to cortical vein thrombosis. And bilateral T2 flare hyperintensities were present in deep white matter. Scoring coming out to be 5. Moving on to our statistical analysis, with a total of 34 subjects, we initially chose a hybrid MRI score with cutoff of 3 for a positive test. As shown in the matrix, this yielded 22 true positive and 2 false positive. Sensitivity was 84.6% and specificity being 75%. It had a high positive predictive value of 91.7% and accuracy of 82.4%. So this is a good rule-out study. This is the ROC curve analysis. Area under curve comes out to be 0.88, confirming the score has excellent diagnostic utility in distinguishing between high and low neuropsychiatric disease activity. Discussion, MRI scoring system has strong diagnostic accuracy in identifying neuropsychiatric involvement in SLE, area under curve coming out to be 0.88, demonstrating excellent discrimination. Patients with SLEDAI score of more than equal to 10 demonstrated significantly higher MRI scores. MRI cutoff 4 showed good sensitivity and specificity for detecting active disease. MRI can detect subtle parenchymal changes, including white matter hyperintensities, infarcts, and microhemorrhages that may not be apparent clinically. This will facilitate better communication between radiologists and clinicians, allowing more objective decision-making. Coming on to the conclusion, MRI serves as a non-invasive marker of CNS disease activity and supports early diagnosis. Integration of MRI findings with SLEDAI enhances comprehensive assessment of NPSLE. MRI findings can effectively identify patients at higher risk, aiding timely interventions. Incorporating the MRI score into routine clinical workflows can enhance multidisciplinary assessment and strengthen the radiologist's impact in SLE management. These are my references. Thank you.
What is this hybrid MRI score? Hybrid?
Hybrid because I'm actually correlating with the SLEDAI, which is the clinical, because there is no histopath correlation, nothing which is there for the confirmation of the diagnosis. Only the thing which is used is the SLEDAI, which is the SLE disease activity index. That is a clinical score. But there is no objective way. So for that objective way, this is used from
They are all known cases of SLE?
Yes, ma'am.
Okay.
Only the known cases of SLE according to ACR Euler 2K19 criteria and presenting with one neuropsychiatric.
And that scoring system you have devised?
Yes, ma'am. Yes, ma'am. Combining different scores
Referring
from the,
to any previous studies?
previous
any?
studies were there, but they were just for including only one parameter. Like for white matter hyperintensities, we have our Fazekas grading. Then for diffuse cortical atrophy, we are using the Pasquier scale.
So what was the sample size?
Sample size was 34, ma'am.
Okay.
Thank you.
Thank you, Dr. Rashi. Next is Dr. Ritesh Kumar Taparia.
Good morning, everyone. So let's talk about intervention as well. So today I'll be talking about a loop-based embolization for a few of the targeted vascular embolization sample cases which were operated in our department. So coming to introduction, what are the endovascular agents? So these are particles and fluids that can be released into the bloodstream through a catheter or microcatheter to mechanically or biologically occlude a target vessel, either temporarily or permanently. So here we use cyanoacrylates. These are the main liquid adhesives used for endovascular interventions and have a major role in managing vascular abnormalities, any bleeding cases or any vascular diseases. So now these are injected as a mixture with ethiodized oil like lipiodol in our cases, which provides radio-opacity and secondary polymerization rate. So coming to aims and objectives, we analyze the composition, properties, and ideal mixture ratios of lipiodol and NBCA combination for various embolization procedures. So materials, practically we assess lipiodol NBCA interactions and emphasizing on that. So we discussed polymerization behavior, their radio opacity, viscosity. So coming to case-based study, so first was AVM and diffuse AVM. So 18-year-old female with complaints of fever and left lower leg and thigh swelling. History of previous embolization was also done. So imaging, as we can see, there's diffuse AVM in thigh and leg with dilated venous channels joining the common femoral vein. So in this image, you can see venous malformations and diffuse AVM. Coming to embolization, so when you took the patient to the DSA, we used the ratio of 1:2, that is cyanoacrylate to lipidol was 1:2 ratio. We can go through direct puncture or diffuse nidus approach also in this case. Now, the use of NBCA, we use onyx also, but nowadays NBCA is preferred in large high flow AVMs. And it also carries a risk of paradoxical embolization. So when the lesion is too small to allow the placement of a catheter across the AVM, glue may allow successful occlusion. So this is during DSA, and post DSA, first image shows the glue tracking across the vessel. Second is the glue cast. This glue cast is basically, it comes with a lipiodol. That's the profit of using lipiodol and polymerization as well. Second was splenic pseudoaneurysm. Now, a 19-year-old male with complaints of hematemesis, who is a known case of chronic calcific pancreatitis and pseudosis. Multiple MPD stentings were done with status post ERCP was also done. Now, imaging-wise, we see chronic calcific pancreatitis with a splenic pseudoaneurysm, which is the most common cause. And splenic subcapsular hematoma also we can see in the images. So it is basically arterial-filled outpouching. Now, pseudoaneurysm, again, we took it to the DSA. There was a small outpouching and extravasation of the dye. So the transarterial embolization with NBCA, it is a proven treatment of traumatic injuries in soft tissue and organ injuries as well. So DSA images, we see, again, the glue tracking through the vessel and sealing of the pseudoaneurysm in this case. Third case was a 50-year-old female complaints of bilateral tingling, numbness with urinary incontinence, and there were no comorbidities. Imaging-wise, you can see MRI shows T2 hyperintensity with few serpiginous flow voids and relatively T2 hyperintense signal combining to congestive myelopathy. So we diagnosed this case as spinal dural AVF. Now coming to again ratios, 1:2 ratio was used. The basic idea was to interrupt the shunt between dural artery and radiculomeningeal vein. So for spinal cord vascular lesions, nowadays NBCA also used when onyx is not possible. So in this case, DSA case, we are seeing this outpouching, that is perimedullary and intramedullary AVF. And second image we see there's a sealed of AVF. Fourth case, hepatic artery pseudoaneurysm, a 45-year-old female with vomitus and epigastric pain. So known case of diabetes and hypertension with duodenal ulcer and status post cholecystectomy, which was the prerequisite for any trauma. Now imaging contrast showed again saccular outpouching, which is arising from the hepatic artery proper at hilum, showing intense enhancement. So again we took it to the DSA, 1:3 concentration was used. Now super selective catheterization was also performed. Post embolization pictures we can see here, glue again tracking through the pseudoaneurysm, and post embolization we see glue cast impression post embolization. Now fifth case, post biopsy renal artery sealed with NBCA. Basically we can see in the imaging hematoma with pseudoaneurysm. Now sticky solution. So what happened, we used approximately 1:3 ratio with renal artery embolization. Again, we can see extravasation in the DSA image. Now post DSA, we can see the glue again tracking. Post DSA, we see there is sealed of cessation of bleeding post embolization. Now jejunal extravasation, this was an interesting case. Just mild enhancement was there in the jejunal loop, so we gave it as extravasation. Then we took this case to the DSA, and then we saw focal extravasation loops. Now again, post DSA, we sealed it with glue with preservation of the major jejunal vessels without ischemia. This was an interesting case where we tried with coiling first. So 71-year-old female with painless hematuria, left renal mass, status post partial nephrectomy. So imaging with revealed focal contrast outpouching, pseudoaneurysm with early venous opacification. So first we did, there was pseudoaneurysm.
Fast forward.
Then we saw outpouching, coiling was done, and through pressure cooker technique, we did again reflux embolization. Now, basic scenario is, basic logic is the higher the flow and the more proximal the lesion is, so we have to put more glue instead of lipidol, so the glue concentration will be higher, and the distal embolization has to be with less glue.
Please conclude.
So my conclusion, effective embolic, it provides effective embolic combination with excellent radiopacity post embolization, and you can adjust polymerization on basis of lesions. Versatile clinical applications in various cases we are using nowadays routinely, and it is safe and cost effective when handled by experienced interventionalists. Thank you.
Thank you, Dr. Ritesh. Next is Dr. Sarli.
Good morning, everyone. My topic is morphometric alteration in the dimensions of corpus callosum in stroke patients using MRI. Corpus callosum is the largest white matter tract in the brain, and it plays an important role in linking right and the left part of the brain, language, intelligence, creativity, and arranging bimanual motor output. Callosal fibers have a particular topographic organization in the brain. That means the prefrontal cortex of the right and the left correlate via the genu and the rostrum. Premotor, supplementary motor, primary motor, sensory cortex link via the body, whereas the parietal, temporal, and occipital fiber correlate via the splenium. Since corpus callosum is a part of brain's highest order growing mental network, measurement of it are essential for determining its physical changes. My objective is to determine the alteration of the corpus callosum in stroke patients using MRI, and also with respect to the age and sex-related differences. It's a hospital-based case control study in our department at the Sum Hospital. We'll be including all the patients with a confirmed clinical and radiological diagnosis of the stroke and age more than 18 years, and we'll be excluding the patients whose clinical presentation could be explained by any other neurological diseases, and the patients with general contraindications to MRI such as pacemakers. This is case 1, in which the measurement of the width of the genu, body, and the splenium is taken at their maximum level in the control, and it is compared with the case which is shown to be reduced. In the case 2, again we have measured the anteroposterior diameter of the corpus callosum at its maximum level in the control, and which is shown to be reduced in the case. These are my results, in which I have found the splenium in the men to be reduced significantly. Worldwide, stroke is among the leading causes of the long-term motor deficits due to the structural and functional reorganization of specific regions of brain. Changes in the white matter integrity after the stroke may result from both axonal degeneration and demyelination, which can also be observed in the regions distant to primary ischemic area, which is therefore correlated to callosal dysfunction. Damage to the cortical neurons can lead to a secondary or Wallerian degeneration of the nerve fibers that originate from those neurons and travel through the corpus callosum. Axonal and myelin damage in the corpus callosum can result in decreased inhibition of the contralesional sensory motor areas. Cortical neuronal damage in the stroke can also reduce cortical benzodiazepine receptor binding, which in turn is highly correlated with the integrity and the function of corpus callosum. The fiber type in the corpus callosum seems to be arranged in an orderly manner. That is, the small slow conducting fibers less than 2 mm With less myelination, they are most populous in the genu of the corpus callosum and the vice versa in the posterior part. Therefore, the splenium is the most affected region of the corpus callosum in post-ischemic insult. Since ovarian hormone drive neuroplasticity, therefore biological sex difference may also influence post-stroke alterations in the corpus callosum. Also, literatures have revealed that corpus callosum in the males have fewer but thicker myelinated fibers. Therefore, the alteration in the morphometry of corpus callosum are most evident in the males as compared to females. Therefore, I conclude there is reduction in the dimensions of corpus callosum in the stroke patients when compared to the normal individual, particularly in the width of splenium of men. Since structural changes of corpus callosum coincide with the differences in the behavioral performance in the post-stroke patient, for example, in form of poor motor recovery. This overall may provide further insight about the neurological sequelae, therapeutic interventions, prognosis, and recovery among stroke patients. These are my references. Thank you.
Thank you, Dr. Surly. Next, we have Dr. Sejal.
Good morning, everyone. I am Dr. Sejal Gatagat. My topic is Beyond the Silhouette, Felson's Radiographic Signs and CT Correlation in the Evaluation of Mediastinal Masses. Mediastinal masses account for 3% of all thoracic lesions detected on imaging, which have various histopathological and radiographic signs. Chest radiograph remains a first-line screening tool for mediastinal evaluation, and Felson's radiographic signs provide a systematic approach to localize and characterize the mediastinal masses. The objectives of the study are to revisit and reinforce the traditional skills of radiographic interpretation among residents and radiologists. This is a retrospective observational case series of 20 patients confirmed of mediastinal masses over a span of 10 months. Imaging protocol was we evaluated these patients on chest X-ray and CT thorax. These are the Felson's radiographic signs: the silhouette sign, hilum overlay sign, convergence sign, cervicothoracic sign, continuity sign, and the spine sign. These signs will help us evaluate mediastinal masses on chest X-ray. On the cross-sectional evaluation, ITMIC classification is used to compartmentalize the mediastinal masses. If it touches sternum, it is anterior; if heart, middle; and if spine, the posterior. Now moving towards the cases, anterior mediastinal masses. Case 1, 69-year-old male presented with sudden onset weakness of left upper and lower limbs and altered sensorium for 5 days. Diagnosed as cerebral infarction, but there were no chest complaints. Chest X-ray was done as a routine workup, on which we found a large radio opacity in left hilar region, on which hilum overlay sign was positive, suggesting it being in the middle mediastinum. And the left heart border was partially obscured, suggesting anterior mediastinal mass. On CT, heterogeneously enhancing mass lesion was seen in the anterior mediastinum, correlating with the X-ray findings. Then case 2. 24-year-old female came with complaints of swelling of jaw and multiple other swellings on the forehead. No other neck complaints were present. On evaluation, chest X-ray showed left paratracheal and superior mediastinal region showed widening with well-defined mediastinal opacity, on which continuity sign was positive and paratracheal stripes were visible, suggesting the neck origin and into the anterior mediastinum. These findings were correlated on CT, and there was a well-defined heterogeneously enhancing mass lesion in inferior to left lobe coming down into the anterior mediastinum. Case 3, 21-year-old male came with complaints of swelling over the face and upper limbs. Chest X-ray showed a large mediastinal opacity silhouetting the heart borders, ascending aorta, the arch, and the SVC border. On CT, we found a ill-defined enhancing soft tissue lesion with lobulated margins. There is infiltration of multiple vascular structures causing SVC obstruction consistent with the symptoms of the patient. Please note the gynecomastia, which is suggestive of germ cell tumor. Moving on, 28-year-old male presented with shortness of breath and retrosternal chest pain. On chest radiograph, we found a rounded opacity in right paracardiac region with hilum overlay sign. Right heart border is silhouetted, suggesting anterior mediastinal mass. On CT, we found a heterogeneously enhancing solid cystic lesion with coarse calcific and fat density region, suggesting teratoma. Then 54-year-old female patient with complaints of pain, abdomen, and loss of appetite for 3 days associated with difficulty in breathing. On chest radiograph, we could see a large partially rounded opacity with central lucency. There is loss of left heart border and the diaphragmatic contour is obscured, suggesting positive thoracoabdominal sign. On CT, there is a hernia in bilateral hemidiaphragm and in anteromedial aspect, correlating with the CT finding. It is Morgagni hernia. Then moving on to middle mediastinal masses, 40-year-old male came with complaints of inability to swallow food and water and throat pain for 15 days. There was history of neck swelling and history of ingestion of seafood. On ultrasound, there was collection with air foci within, and cervical X-ray showed subcutaneous emphysema. On chest X-ray, there was a well-defined opacity causing mediastinal widening and silhouetting the aortic knuckle. CT showed collection with multiple air pockets in various neck spaces extending into the middle mediastinum. Also, there was a hyperdense foreign body noted which suggested fishbone, and there was a rupture in esophagus. Focal aneurysmal dilatation was of distal part of arch of aorta was noted as a complication. Then case 7, 45-year-old male patient came with complaints of weight loss, cough, and fever for 4 months. The B complaints were positive, and the chest radiograph showed mediastinal opacity silhouetting the right heart border and aortic knuckle. Hilar vessels could not be seen. That means the hilum overlay is negative, suggesting the middle mediastinal mass. CT showed homogeneously enhancing grossly enhanced mediastinal lymph nodes, which later on were confirmed to be non-Hodgkin's lymphoma. Then moving on to posterior mediastinal masses, 27-year-old male patient presented with complaints of lower back pain since 2 months. Then on chest X-ray, there was a bilateral linear paravertebral opacity with maintained cardiac silhouette. The mass is seen to extend below the diaphragm, suggesting posterior mediastinal mass, and multi-level spondylodiscitis is in dorsolumbar spine with large pre- and paravertebral collection was noted, suggestive of Cox and correlating with the chest X-ray finding. Then, 22-year-old male patient, a known case of neurofibromatosis, presented with complaints of left-sided chest pain, cough with expectorations for 6 months. Chest X-ray showed large, well-defined opacity in left paracardiac area. Heart border is seen through the mass, suggesting posterior mediastinal origin. Paraspinal line is obscured, and mass is seen indenting into the heart and indenting onto the heart and descending aorta. The epicenter appears to be in posterior mediastinum, extending into the middle. On CT, there was a well-defined heterogeneously enhancing mass on posterior mediastinum. The mass is abutting the vascular structures anteriorly. This is a case of extramedullary hematopoiesis diagnosed incidentally while evaluating the patient for cirrhosis and ascites. On chest radiograph, the sign is negative. We cannot delineate the structure, but on CT we could see the extramedullary hematopoiesis adjacent to D9 and D10 vertebral bodies consistent with extramedullary hematopoiesis. These are the results. Anterior mediastinal masses out of 9, we could diagnose 7 on the chest X-ray.
Please conclude.
Okay. The conclusion is a balanced approach highlighting old eyes with new tools defines the future of radiological excellence. CT interpretation is vanishing art during this rapid CT dependence era, which deserves revival in modern radiological training, because sometimes all it takes is silhouette to tell a story. Thank you.
Thank you, Dr. Sejal. Now we have Dr. Simran Garg.
Good morning, esteemed judges. I'm Dr. Simran Garg, postgraduate resident from KIMS Bhubaneswar, and my topic today is imaging the etiology of orbital apex syndrome. The orbital apex represents a small, anatomically complex craniofacial junction responsible for transmitting a number of cranial nerves. Orbital apex disorders present with ophthalmoplegia, with or without vision loss. A number of etiologies can be responsible for the same symptoms of orbital apex disorders. Thus, imaging plays an important role in early diagnosis and saving vision. The orbital apex incorporates the optic canal and the superior orbital fissure. The optic canal transmits the optic nerve and the ophthalmic artery. The superior orbital fissure transmits the third, fourth, and sixth cranial nerve along with branches of the first segment of trigeminal nerve. This is a CT axial and coronal image showing the optic canal medially and the superior orbital fissures inferolaterally separated by the anterior clinoid process indicated in pink. These are the MRI images showing the optic canal in pink and the superior orbital fissure in blue. The etiologies can be divided into infectious, inflammatory, neoplastic, traumatic, and vascular. Infectious etiologies include fungal infections, orbital cellulitis. Inflammatory etiologies include Tolosa-Hunt syndrome, IgG4 related diseases, sarcoidosis. Neoplastic etiologies can vary from gliomas, meningiomas, metastasis, schwannoma. Vascular lesions can include cavernous sinus thrombosis, keratoco-cavernous fistulas, and even ICA aneurysm. There can be traumatic and iatrogenic etiologies as well. The aims and objectives of my study: to describe the imaging spectrum of the orbital apex disorders across etiologies and emphasize the key CT and MRI features aiding in etiological differentiation. And the objective is to analyze various radiological findings in patients with orbital apex disorders using CT and MRI and correlating them with the clinical history to guide the management. This methodology, this is a case series approach with 25 cases with orbital apex disorders varying in etiology were included. For all patients, CT and or MRI was done. The 5 representative cases will be used to illustrate the 5 principal etiologic categories. First is vascular. Patient presented with a history of RTA 4 years ago with blurring of vision for the last 3 years, resulting in complete loss of vision in the right eye. On examination, the patient showed bilateral pulsatile proptosis. In the images below, we can see axial T2 images showing bilateral bulky cavernous sinus with dilated and tortuous phlovoid, suggesting bilateral direct keratico-cavernous fistula, which is Barrow's class A. On axial T2 image, we can see the phlovoid is seen extending to the superior orbital fissure and compressing on the right optic nerve. In the DSA image, we can, this was confirmed by DSA, where we can see filling of bilateral cavernous sinuses. This patient was treated with endovascular coiling. And after endovascular coiling, which was done on the right side, the patient experienced improvement in symptoms. A 67-year-old female patient presented with pain in case 2 infectious etiology. A 67-year-old patient presented with pain in left eye associated with gradually progressive swelling and blurring of vision since 2 months. On axial T2 flare images, a loculated collection in left retroorbital space was noted, which showed diffusion restriction on DWI and ADC images. The surrounding extraocular muscles were edematous and the retroorbital fat stranding was noted. Then on the left optic, in this image, we can see that the left optic nerve was compressed at the orbital apex, and the orbital apex nerve involvement was seen with T2 hyperintensity, showing diffusion restriction in the image below, and patient was managed with antibiotics. Third case, patient came with complaint of severe headache, proptosis of left eye, along with decreased vision in left eye since 2 years. A well-defined extra-axial lobulated heterogeneous T2 flare hyperintense lesion with cystic spaces was noted in the intracorneal space of the left orbital fissure, which was showing intracranial extension through the optic canal and the superior orbital fissure. The lesion is seen compressing on the optic nerve and is associated with cavernous sinus compression or thrombosis. On histopathology, the tumor was revealed to be an optic nerve sheath tumor, and the patient underwent excision of the tumor with duroplasty. Case 4. A 35-year-old female presented with complaints of painful ophthalmoplegia, progressive diminution of vision in the right eye, and severe headache since the last 7 days. T1 post-contrast images shows asymmetric thickening of the right cavernous sinus dura with associated enhancing thickening along the anterior temporal dura. On extension of the enhancing thickening to the orbital apex was also noted. Patient was diagnosed with Tolosa-Hunt syndrome and received rapid improvement of symptoms after administration of corticosteroids. Case 4 trauma, the patient had a history of RTA and presented with proptosis. Here we can see a fracture of the right lateral wall of orbit with focal segmental hyperenhancement of the right optic nerve. Axial post-contrast image showed filling defect in the right cavernous sinus as well, suggestive of thrombosis. Results: out of the 25 cases that were included, 9 were inflammatory, which was the most common etiology, 6 were infective, 4 neoplastic, 4 traumatic, and 2 vascular. The main imaging findings for each etiology are as follows. Infective lesions will have ill-defined heterogeneous lesions which with associated fat stranding with or without abscesses.
Fast forward. Conclude.
Neoplastic depends on the etiology. Conclusion: orbital apex syndrome represents a common final pathway of diverse pathologies. Although the clinical manifestations appear uniform, the imaging patterns are distinct varying on the etiology. Thus, enhanced MRI is required. These are my references. Thank you.
Thank you, Dr. Simran. We'll begin with the final set, and I would like to call Dr. Harsh.
Good morning to all. My topic for today is assessing brain network connectivity in patients with glioma, resting state functional MRI study. Briefly about gliomas, there are the most common CNS tumors in adults with a very high morbidity and mortality, and which leads to poor quality of life. The recent evidence suggests that it is actually a diffuse brain infiltration which extends beyond the visible tumor boundaries, which are usually seen on conventional modalities like CT or conventional MRI. So, resting state functional MRI is a relatively novel tool which can demonstrate altered functional connectivity, reflecting both the local and distal effects, which can possibly help in better prognostication of the patients. So, with this study, our aim was to firstly check the differences in functional connectivity between glioma patients and healthy controls, and also if we could see any correlation with the conventional MR features or WHO tumor grade, etc. This was a prospective case control study. So, initially, patients with suspicion of glioma were recruited, and along with them, healthy controls were recruited. So, we excluded patients who were less than 18 years and who had a history of past cranial surgeries. Then around 37 patients and 30 normal controls underwent MRI, out of which due to excessive motion some patients were excluded, and on post-op biopsy one patient did not have glioma as the diagnosis, so he was also excluded. Then finally 28 cases and 28 controls were taken for final analysis. MRI was done on a 3 Tesla scanner using a 32 head channel coil. We used all routine sequences except for this high resolution anatomical sequence, which is 3D T1 Bravo, and functional sequence, which is this axial resting state connectivity sequence. We classified all the tumors into conventional features. First was necrosis, which was defined as high signal intensity on T2 weighted images with corresponding low signal on T1 and irregular enhancing border. So in this T2 weighted image, central high signal and corresponding peripherally enhancing area suggests necrosis. Then contrast enhancement was seen on T1 weighted and compared to signal intensity of the adjacent fat. So this was like no contrast enhancement. This was mild, which is less than the surrounding fat signal, and this was marked, which was similar or more than the surrounding fat. Then lastly, peritumoral edema, which was the distance between the tumor margin and the outer edge of the edema. So mild was defined as less than 1 centimeter of distance, and marked was defined as more than 1 centimeter of distance. Briefly about the pre-processing pipeline that we used. Initially, the native anatomical, which is the Bravo T1 image, and functional image were required. Then skull stripping and realignment was done. Here we can see the skull has been stripped out and the image has been realigned. And then segmentation into gray matter, white matter, CSF species, etc. were done. Then all the patients were normalized to account for the variability in the anatomy. Finally, denoising was done to exclude outliers, and this resultant map we can see where predefined areas like the medial prefrontal cortex is seen on the functional map. Results, the demography, the mean age was early 40s with similar sex distributions, and size was increasing from grade 2, 3 and 4 tumors. Necrosis was absent in all, and mostly present in grade 3 and 4 tumors, and contrast enhanced peritumoral edema was also increasing with increased tumor grade. This is just connectome maps showing, here we can see glioma patients and normal subjects. These red bands show connectivity between different regions. So we can see grossly that glioma patients have reduced connectivity. Then we basically saw a default mode network and salience network. So default mode network predefined seeds were like medial prefrontal cortex, lateral parietal lobe and posterior cingulate cortex. This was the table for the left side patients, and this was for the right side glioma patients. Here, a 3D surface map shows reduced connectivity in the left frontoorbital cortex in the left side tumors and the right frontoorbital cortex in the right side tumors. Also, this axial image shows the same thing. Similarly, for salience networks, there were some predefined seeds, and we found similar differences in both the left side and the right side tumors, which were namely the posterior occipital cortex and the supramarginal gyrus.
Try to wind up.
Finally, there was significant correlation with tumor grade, especially in the frontoorbital cortex. Here we can see the left side gliomas with a Pearson coefficient of R equal to 0.37. For right side, R was 0.47. So primary outcomes were overall reduced functional connectivity, and which were also seen in contralateral hemispheres. Secondary outcome was there was positive correlation with the tumor grade. So recent similar studies have shown similar results. However, tumor grade was a new finding which has not been seen, and some studies also show correlation with patient outcomes. However, longitudinal studies are required. So these are my references. Thank you.
Thank you, Dr. Harsh. Next, we have Dr. Tina.
Good morning, everyone. My topic is radiomics evaluation for predicting molecular subtype of CA breast by USG and mammography. Breast cancer is a heterogeneous disease with various molecular subtypes, each exhibiting distinct biological behaviors and clinical outcomes. Accurate classification of these subtypes is crucial for personalized treatment strategies and prognosis. Traditionally, molecular subtyping relies on tissue biopsies, which can be invasive, costly, and time-consuming. Recent advancement in imaging technologies, particularly ultrasound and mammography, offer a non-invasive approach to assess tumor characteristics, but their ability to predict molecular subtypes remains underexplored. Radiomics, the extraction of quantitative features from medical images, has emerged as a promising tool for predicting the molecular profile of tumors. By analyzing various parameters in images from USG and mammography, radiomics may provide insights into the underlying biology of breast cancer, potentially allowing for the identification of molecular subtypes without the need for biopsy. The aims and objectives of my study were to evaluate the potential of radiomic features extracted from ultrasound and mammography images for predicting the molecular subtypes of breast cancer. The methodology was patients presenting with complaints of breast mass underwent ultrasonography of bilateral breast and axilla, and the largest section of ultrasound in each lesion was selected for analysis. They also underwent digital mammography. The characteristics of the lesions or ultrasound and mammography were recorded, tabulated, and analyzed. The histopathological diagnosis was determined with specimens got by biopsy and FNAC. The inclusion criteria was symptomatic patients presenting with breast lump. Exclusion criteria was history of prior neoadjuvant chemotherapy, prior cancer treatment, bilateral breast cancer, and those unable to undergo histopath and IHC examinations. This is the first case. It is a case of triple negative breast cancer. The mammogram shows a high density circumscribed mass, whereas the ultrasound shows circumscribed hypoechoic mass with posterior acoustic enhancement. The second case is of HER2 enriched invasive cancer. High risk microcalcifications are seen on mammogram, and irregular hypoechoic mass showing increased internal vascularity and internal echogenic foci representing microcalcifications was seen on ultrasonography. In the results, the molecular subtype distribution was as follows. The luminal A was approximately 51% of all the cases, luminal B 14%, HER2 enriched 18%, and triple negative breast cancer was 17%. The posterior acoustic enhancement, circumscribed margins, were strongly associated with triple negative breast cancer. High vascularity, Adler index 2/3, tumor size more than equal to 20 mm, and axillary nodes were associated with both HER2 positive and triple negative breast cancer. Microlobulated margins, high risk microcalcification was predictive of HER2 plus subtype. Posterior shadowing was typical of luminal A cancers, and speculated margins were characteristic of luminal A/B cancers. In conclusion, ultrasound and mammogram findings strongly correlated with molecular subtype. Luminal A tumors were small, spiculated, and showed posterior shadowing. HER2-enriched cancers had microlobulated margins, high vascularity, and microcalcifications. Triple-negative breast cancer appeared benign-like, circumscribed margins, posterior enhancement, and large size. Tumor size was the strongest independent predictor for triple-negative breast cancer. These are my references. Thank you.
Thank you, Dr. Tina. Next, we have Dr. Vinila.
Good afternoon, everyone. My topic is diagnostic validity of arterial spleen labeling in grading of adult CNS gliomas. ASL is a non-ionizing and completely non-invasive MRI technique which uses labeled arterial blood water protons as an endogenous tracer. Gliomas are characterized by high morbidity and mortality with low cure and high recurrence, which depends to a greater degree on the angiogenesis of the tumor. Assessment of such angiogenesis by perfusion techniques is of utmost importance for the preoperative grading of gliomas. WHO grading includes grade 1 and grade 2 as low grade, while grade 3 and grade 4 are more aggressive high-grade gliomas. Glioma grades determine surgical strategy, adjuvant therapy, and overall prognosis. My aim and objective is to assess diagnostic accuracy of ASL perfusion technique in grading of gliomas prior to surgery, correlate those findings with histopath and molecular markers. A cross-sectional study was done for 43 patients in the Department of Radiodiagnosis, IMS Some Hospital, from May 2024 to 2025 October, which included patients more than 18 years of age of both sexes and excluded patients of post-management patients who came for follow-up, patient with a history of claustrophobia or any other CNS lesions other than gliomas. MRI examination were performed on a 3 Tesla scanner, which included pre-contrast T1 axial, T2 axial, sagittal and coronal, T2 flare sequences, DWI and ADC. Perfusion imaging was performed using a 3D pseudo-continuous arterial spleen labeling and post-contrast T1 images. Here we, in the principle of ASL, we acquired 2 sets of images, tagged and control. Tagged using RF pulses to inflowing arterial blood by magnetic inversion. After allowing some delay, we acquire tag images. Then control images are also acquired without tagging. Subtraction of these images provides ASL data. Then relative cerebral blood flow is a ratio obtained by comparing blood flow in the tumor region to that of the contralateral normal white matter. Region of interest placed on the region with highest CBF, avoiding vessels, cysts, necrosis, and artifacts. Here is the case which shows irregular ill-defined lesion in the anterior temporal lobe, left anterior temporal lobe, involving cortex and subcortical white matter, which is T1 hypointense, T2 flare hyperintense with no diffusion restriction and no blooming on SWI. It shows a thin peripheral enhancement and no perilesional edema. CBF map shows iso to hypoperfusion of the lesion with ASL relative CBF value of 0.72, consistent with low-grade glioma. On histopath, it came out to be a diffuse astrocytoma, IDH mutant WHO grade 2 type, which shows positive for IDH and GFAP and loss of expression of ATRX marker. Here is another case which shows irregular infiltrative mass involving splenium of corpus callosum, which is T1 hypointense, T2 flare iso to hyperintense, showing diffusion restriction. It shows heterogeneous enhancement and intralesional blooming on SWI. CBF map shows hyperperfusion of the lesion with CBF, relative CBF value of 4.76, suggestive of high-grade glioma. On histopath, it came out to be a glioblastoma, IDH wild type, grade 4, which is positive for GFAP marker, negative for IDH, and retained ATRX expression. ASL showed hypoperfusion pattern in 14 out of 17 patients, which has relative CBF less than 1.5, and 21 out of 26 patients showed hyperperfusion on high-grade gliomas, which shows relative CBF more than 2. Hence, ASL relative CBF shows excellent diagnostic accuracy in differentiating lower and higher grade gliomas with high sensitivity and specificity at an optimal cutoff of CBF value more than 2.08. Hence, ASL proved to be a reliable, non-invasive, contrast-free technique for assessing tumor vascularity in gliomas. Quantitative relative CBF values derived from ASL showed significant correlation with histopath. High-grade demonstrated marked hyperperfusion with elevated CBF values, reflecting increased tumor angiogenesis and microvascular density, whereas low-grade gliomas exhibited hyperperfusion and lower CBF values with their lower cellularity and reduced metabolic activity, hence making it as a valuable diagnostic tool, especially when contrast uses and contraindicated. Thank you. Here are my references. Thank you.
Thank you, Dr. Vanilla. Next is Dr. Jocelyn.
Good morning, everyone. So my topic is the reversible brain signatures of metabolic encephalopathy. Metabolic encephalopathies represent a spectrum of potentially reversible brain dysfunction caused by either systemic metabolic causes or any toxic disturbances. MRI plays a vital role in early identification of these entities and providing a characteristic pattern that help us to distinguish them from an irreversible brain structural lesions. Prompt recognition of these reversible patterns can guide management and prevent long-term neurological morbidity. Even before lab investigations, MRI can play a significant role in determining the metabolic encephalopathies. So my objective is to evaluate the imaging finding of metabolic encephalopathies on MRI and then correlate with clinical lab parameters and determine significance in differentiating various metabolic causes of altered sensorium. I have done a retrospective descriptive type of study where I've taken into account 25 cases, and over here I've taken 9 representative cases. Normal imaging protocol was used, which is T1, T2, T2 flare and diffusion weighted images, and in few of the cases I've taken ASL into account. Then clinical correlation with the biochemical parameters was performed to confirm the etiology. Case 1 was acute hepatic encephalopathy, which was hyperammonemia. Patient was 45-year-old male, which presented to the ER department with altered sensorium and seizure. He was a known case of CKD and has history of yellowish discoloration. Lab investigation revealed increased serum ammonium level in this. As we can see in the images, there is symmetrical T2 flare hyperintensities in bilateral thalami, caudate and lentiform, and cerebral cortices, with increased perfusion on ASL images at this cerebral cortex level. We'll see that there is a typical sparing of perirolandic and occipital lobes in this, as we can see on the subsequent images along with the ASL. Perirolandic and occipital lobes are spared due to glutamate mechanism because these lobes doesn't have glutamate pathways. Next case is the osmotic demyelination case, which was 48-year-old male presented with altered sensorium. He was a known case of CKD and had coronary artery disease history, was hypertensive. His lab investigation initially revealed that there was serum sodium level of 131. As we can see on images, flare and diffusion. There was T2 flare hyperintensity with altered diffusivity in the paramedian region of the pons and typical trident sign, which we can see on these images. Coming to the third case, which is kernicterus, a 10-days-old male baby presented with yellowish discoloration of the eyes and has history of seizure. He was a known case of G6PD enzyme deficiency. His lab investigation revealed increased bilirubin level. As we can see that on T1 weighted images, there is bilateral symmetrical T1 hyperintensity in globus pallidi. Coming to the fourth case, which was hypoglycemic encephalopathy, 28-year-old alcoholic patient presented to ER with unconscious state. We can see on T1 image that there is hypointensity in bilateral caudate and right lentiform nuclei, asymmetrical type of presentation features, and then flare also we can see there is hyperintensity and there is diffusion restriction on subsequent diffusion weighted image. Fifth case was diabetic steatopathy. A 76-year-old male came to ER with involuntary movement of hands and delirium. His serum glucose level was 191. As we can see on T1 weighted images, there is hyperintensity in bilateral basal ganglia, which is corpus striatum. That is why known as steatopathy. And there is flare hyperintensity involving basal ganglia region.
Coming to case 6, it was hypercalcemic encephalopathy. Patient was 38-year-old female which came to ER with pain, abdomen, loose stools and altered sensorium. On further workups, patient was came to be known case of CA lung. So hypercalcemia was due to the paraneoplastic syndrome. In the imaging finding, we can see that there is a gyral swelling and flare hyperintensity in bilateral frontal and parieto-occipital regions. Coming to 7th case, which is posterior reversible encephalopathy syndrome, 29-year-old pregnant female presented with seizure history. She was a known case of eclampsia. As we can see, there is a subcortical symmetrical flare hyperintensity showing altered diffusivity in bilateral parieto-occipital, frontal and cerebellar hemisphere. As cerebellar hemisphere was involved in this case, it was atypical type of press. Coming to case 8, it was uremic encephalopathy. A 53-year-old male presented with seizure history, known case of CKD. His serum urea level was 110. We can see symmetrical flare hyperintensity in bilateral potamina with surrounding edematous external capsule giving a typical lentiform Fox sign over here. Then was the Wernicke's encephalopathy. 61-year-old female presented with repeated vomiting since 2 months, now showing with altered sensorium, known case of D1, D2 stricture. As we can see, there is a symmetrical flare hyperintensity with altered diffusibility in dorsomedial thalami, mammillary body and periaqueductal region. So results were age range was 10 days to 76-year-old. Common presenting symptoms was altered sensorium and seizure. And there was reversibility in all these cases. This was the sum up of all the 9 cases which were there. And this was the table summary where there was recovery in all the cases, taken into account 25 cases. So conclusion is MRI demonstrate pattern specific distribution correlating with the etiology. Basal ganglia and cortical involvement are consistent with the markers. Early correction of metabolic abnormality can lead to full recovery of the patient. Reversibility on MRI is in hallmark of metabolic brain dysfunction. So the reversible brain is a radiological reality. Recognition, its pattern can change the outcome of the patient. Thank you.
Thank you, Dr. Jaslin. Before moving on to the next speakers, I would like to call upon Dr. Suprabha Naik ma'am, HOD Department of Radio Diagnosis and our organizing chairperson, to felicitate our judges. First, I would like to call upon Dr. Jayashree ma'am. Thank you, ma'am. Next, I would like to call upon Dr. Gitanjali ma'am. Thank you, ma'am. Next, I would like to call upon Dr. Feni Chakraborty, sir. Thank you, sir. Lastly, I would like to call upon Dr. Sudipta Mohakud, ma'am. I would like to request Dr. Sudipta ma'am to kindly facilitate our HOD, Dr. Suprabha ma'am. Just a moment, ma'am. Kindly, I would request all the judges to come to the stage for a photograph. I would also request Dr. P.K. Das, President of ORIA, to kindly come on the stage for a photograph with the judges.
Our Vice President ORIA, Dr. Suray Murmu sir, to come on the stage. Dr. Santi sir and Dr. Subhendu sir also please come on the stage. We'll have a common photograph.
I would like to request Dr. Sudipta ma'am to kindly facilitate Dr. Shanti sir and Dr. Shanti Bhushan sir. Kindly come on this, can you please come on the stage, sir? I would like to request Dr. Sudipta ma'am to facilitate Dr. Shanti sir. Next, I would like to call on the stage Dr. Subhendu sir. Somendu sir.
Dr. Subhendu Mahapatra sir. Suray Murmu sir to come on the stage.
Thank you so much, sir. Thank you, ma'am. We'll continue with the next presentation. So we have Dr. Rinkita Malik.
Good morning, everybody. This is Dr. Inkita going to present my study on AI empowering radiologists. My topic is using radiomics, how Indian radiologists can differentiate a tuberculoma from a malignancy. So starting with the objectives. The objectives were to evaluate CT-based radiomics for differentiating tubercular graminomas from lung adenocarcinomas. For this, we extracted the quantitative features using 3D slicer and applied pyradiomics on that. And finally, develop a non-invasive diagnostic tool feasible for high TB settings. So understanding the solitary pulmonary nodules, these are usually single nodules of diameter 1 to 3 centimeter seen on chest imaging. And coming to the diagnostic dilemma, in a high TB prevalent country like India, usually the tubercular granulomas mimic malignancy. Both of them share the common clinical features. Even on CT, the morphological features even overlap. On PET CT, both of them take up the uptake, resulting in misdiagnosis, unnecessary biopsies, and delayed treatment. So this is where we can use radiomics. So this is a visual representation of how radiomics is used. On the left hand side, you can see how we humans generally perceive a solitary pulmonary nodule. And on the right hand side, how the AI sees the solitary pulmonary nodule. It divides the nodule into hundreds of blocks and then analyzes each block pixel by pixel and generates its textural differences, pixel intensity, shape irregularities, and micro heterogeneicities, which is impossible for our eyes to detect. This it now gives colors to these boxes. The green boxes showing more homogeneous pattern in the nodule, and the yellow and the red boxes showing more heterogeneous suspicious areas in the nodule. Now this slide summarizes my entire material and methods. To start with, I did the patient selection. This is a retrospective study where we collected 28 number of biopsy proven, micrologically proven cases of TB and malignancy, and then applied the data to form two models. In the above path, you can see the blue model where we use the conventional CT features and clinical features to derive a model. And to compare our conventional imaging features, we made the radiomix model that is in the red color. In this, we generated our radiomix model, and finally, we compared the diagnostic accuracy of both to see which of the model performs better. So for applying the radiomix, our first step is segmenting our region of interest. This is where you can see how we are beautifully delineating the region of interest, and then generate a three-dimensional figure of our nodule. To this three-dimensional figure, we'll apply radiomix. So this is how radiomic features are extracted. So these set of features are divided into three types. First is the first order statistics, which tells us about the intensity, brightness, contrast of each pixel. Then comes the shape features, which tells us about the three-dimensional geography or the margins or the three-dimensional volume of the nodule. And finally comes the texture features, which is the power of this radiomix, which tells us about the heterogeneity, irregularities, homogeneities that is present in the nodule, which is not seen by human eye, which is seen by radiomix, which makes it work like a supercomputer. So after we have generated thousands of features, we need to segregate only the relevant features which will be helpful in segregating our nodule from a malignancy and tuberculoma. So you are seeing here there are multiple of features, and then we applied a filter called the lasso. The lasso then segregated the most relevant important features. Now we have got the most important features with us, and then we submit each of these features for a particular patient and give them a score which is called a RAD score. The persons are then plotted in a graph. So in this case, in this graph, you can see our all 28 patients are plotted, and each bar represents a person. So each person has a definite RAD score based on their textural features. And the pool of patients coming on the TB category had low RAD scores in the negative, and the pool of patients coming on the red side belong to the malignancy category having positive RAD scores. And thus, we can differentiate all of these patients and their nodules on the basis of their textural differences. So this is how our final radiomix model has been made. The next step is to perform a diagnostic accuracy tool to see which of the model, the conventional CT model or the radiomix model, which one performs better. So this is how we are going to perform a diagnostic analysis to see which of the model is performing better. So first one is the ROC curve for the conventional modeling. We can see here a AUC of 0.6 representing that this performs well with the nodule. It well differentiates a nodule from TB and malignancy. Now coming to a radiomix model. Here the AUC is 0.78, showing that it performs better than the conventional model. And finally, our combined model, which has the AUC of 0.93, showing that it performs the best. And lastly, we have validating our results comparing with the biopsy. And each of our RAD scores showed exactly what the biopsy features show. So showing the diagnostic accuracy of our radiomix model. And finally, after taking out all the features, we now show you the final nomogram, which contains all the specific features to differentiate a nodule from malignancy and tuberculoma. So in this we see various features, and then there is RAD score, and the summation of all these points gives us a total score, which directly gives us the prediction risk for the particular nodule. Thank you.
Software you used for radiomic analysis?
Ma'am, for the segmentation, I use 3D slicer to segregate our region of interest. And in that 3D slicer, we have the tool called PyRadiomics, which extracts the radiomic features, does the texture analysis.
So validation?
Yes.
28 cases you have done.
Yes, ma'am. This is a pilot study,
Pilot.
so we had very less number of cases.
So you will further validate it with other cases.
In the further stage, we will try to do it in a multi-stage, multi-center data will collect and do it in a larger way, so that the tests.
Where you have done this study?
MKCG, MCH, ma'am.
MKCG.
Yeah.
Okay.
Thank you so much.
Thank you, Dr. Rinkita. Next is Dr. Utsav Daga.
My topic is role of diffusion weighted imaging in early detection and staging of urinary bladder carcinoma, a prospective cohort study. So bladder cancer is the fourth most common cancer in men, with painless hematuria being the most common presenting feature. Smoking remains the major risk factor. Most tumors are of urothelial origin, with roughly 1/4 of them being muscle invasive at the time of diagnosis. Currently, multiparametric MRI is used to provide both anatomical and functional assessment. The aim of my study was to evaluate the diagnostic accuracy of diffusion-weighted MRI in local staging and grading of urinary bladder carcinoma, correlating imaging findings with histopathology. My objectives were to assess DWI accuracy in detecting muscle invasion and local tumor staging using histopathology as the gold standard, correlate ADC values with tumor histological grade, as well as evaluate combined diffusion-weighted and T2-weighted imaging for improved differentiation between non-muscle invasive and muscle invasive bladder cancer. We studied 40 cases over 2 years as per the inclusion and exclusion criteria mentioned here. All the cases had complete multiparametric MRI assessment with adequate patient preparation. In image analysis, we combined interpretation of T2WI, DWI ADC, and DC was used. ADC maps were generated in the tumors that were large enough, that is greater than 5 mm, to contain the region of interest. The ADC values were calculated to evaluate the degree of diffusion. In my study, 80% of the cases were male, whereas 20% were female. The mean age of the patients was 51 years. Most common morphology was nodular, that was in about 52.5% of the cases, whereas sessile was the least common morphology in 20% of the cases. 50% of cases were less than 5 cm, whereas rest 50 were greater than 5 cm. Most common histological pattern was found to be transitional cell carcinoma in 87.5% of the cases, whereas only in 2.5% cases we found it to be adenocarcinoma. High-grade predominance was noted. In about 57.5% cases, we found T2 hyperintense signal, and in 95% cases, diffusion restriction was noted. 42% of our cases were of T3 stage, whereas T2 stage was least common. In this bar diagram, we can see that T2 weighted plus DWI imaging markedly outperforms T2 alone in terms of sensitivity, specificity, with overall accuracy of combined being 95%, whereas of T2 alone is 80%. Area under the curve also improved from 0.73 to 0.93, shifting from moderate to excellent performance. Thus, adding DWI markedly improved reliability to detect muscle invasion, giving us a strong diagnostic confidence for treatment planning and staging. The box plot clearly shows the separation between benign and malignant lesions. The benign tumors have higher ADC values, that is greater than 1.45 into 10 to the minus 3, whereas malignant lesions have lower values. These heat map demonstrate strong inverse correlation of ADC with tumor grade and muscle invasion. By morphology, papillary lesions have highest ADC value, whereas sessile have the lowest, in range of about less than 1 into 10 to the minus 3. Thus, ADC inversely correlates with cellularity and malignancy from papillary to sessile forms. In this case, we can see an irregular polypoidal intraluminal mass arising from posterior superior bladder wall. On T2 axial and coronal images, the lesion appears isointense with diffusion restriction seen on DWI imaging. There was low signal on ADC maps indicating high cellularity. There is transmural involvement with mild perivesical fat extension. However, no invasion of adjacent pelvic viscera and bilateral VUJ was seen. Histopathologically, it came out to be muscle invasive high-grade papillary urothelial carcinoma without lymphovascular or perineal invasion. In this case, there is an irregular heterogeneous hypo to isointense lesion in antral bladder wall extending intraluminally, prominently on the left side, with diffusion restriction on DWI and involvement of muscularis propria. There is mild extension of perivesical retropubic space. However, no invasion of prostate or bilateral VUJ was seen. On histopathology, it came out to be high-grade papillary urothelial carcinoma with tumor necrosis. Therefore, T2 plus DWI markedly improved staging accuracy with respect to T2 alone. Improvement in diagnostic accuracy aligns with the meta-analysis for detecting non-muscle invasive versus muscle invasive bladder carcinoma. ADC showed strong inverse correlation with grade, that is, lower ADC values indicate high cellularity and aggressiveness. ADC acted as a reliable non-invasive biomarker for risk stratification and treatment planning. Overall, findings of my study align with international evidence and add Indian cohort validation for usage of DWI with T2 and as well as usage of ADC in staging and grading. Takeuchi et al. Showed DWI improved staging and L. Semi et al. Showed ADC improves inversely correlates with grade, strongly replicated in our cohort. My study's main limitations that are but not limited to small sample size and high iteration rate. Key takeaways of my study were that is combined usage of T2 and DWI enhances detection of muscle invasion. Lower ADC correlates with higher grade morphology and aggressiveness that guides treatment and management. Thus, multiparametric MRI can serve as a potential non-invasive adjunct to TRBT. Future prospects are integration of advanced imaging modalities such as radiomics, artificial intelligence, and functional MRI. These are my references. Thanks a lot.
Thank you, Dr. Utsav. Now I would like to call upon Dr. Siddhant Kumar Tripathi.
Good afternoon, respected chairpersons and my dear colleagues. I am Dr. Siddhant from SCB Medical College. Today I'll be presenting a comparative CT coronary angiography study on diabetic versus non-diabetic patients. Coronary artery disease is the leading cause of morbidity and mortality globally. In India, the prevalence is around 21% for diabetics and 11% for non-diabetics. Diabetes accelerates atherosclerosis and increases the likelihood of diffuse multivessel coronary disease. CT coronary angiography combined with calcium scoring allows us to assess stenosis severity, plaque morphology, and plaque vulnerability in a single non-invasive examination. The aims of my study were to characterize plaque morphology and luminal narrowing of coronary arteries, to calculate the calcium score using MDCT, and to compare the severity in non-diabetic and diabetic patients. Now, we conducted a study, observational study with 100 patients with 50 diabetics and 50 non-diabetics. The inclusion criteria were given as in the slide. Every artery was assessed on basis of stenosis, mild, normal, mild, moderate, severe, and total occlusion, presence of vulnerable plaque features, plaque type, and number of vessels involved. The demographic profile shows diabetic patients were slightly older and had more hypertension and dyslipidemia compared to non-diabetics. Mixed plaque which are biologically more stable, were 3 times more common in diabetics, 45%, compared to 15% in non-diabetics. Moderate LAD stenosis was seen in 36% of diabetics and seen in non-diabetics across all the arteries. Non-diabetic showed more normal LAD, 90% versus 48% in diabetic patients. This is the calcium score comparison. Diabetics had almost double the CAC, 214 versus 108, representing 98.7% higher calcium burden. And importantly, CAC above 400 was seen only in diabetic patients. Triple vessel disease was dramatically higher, which is 7-fold in diabetics compared to non-diabetics. And a double vessel involvement was also significantly higher, 3 times than non-diabetics. Now, this is a diabetic patient showing diffuse plaques, mixed morphology plaques, and moderate stenosis, illustrating the typical diabetic pattern. In contrast, the non-diabetic patient shows focal, stable, calcified plaque with a low CAC and minimal stenosis. Now, we also found a strong positive correlation between the duration on diabetes and the calcium score. Hypertension further amplified the calcium burden amongst diabetics. Calcium burden increased with the duration of diabetes and highest in patients with both diabetes and hypertension, with a mean CAC of 317. Now, this is a case that shows high calcium burden and focal severe stenosis in RCA and LAD, which shows diabetics often have high CAC and calcified multivessel disease even with mild symptoms. Another case showing low calcium burden, but and a single small plaque in RCA. Now it shows low CSE will not rule out symptoms, but it usually indicates that they are stable plaques and have low risk anatomy. This is another case having very low CSE, and this is a case of history of CAD, but we found no very low CSE and normal coronaries with minimal non-obstructive disease. These are the features of vulnerable plaques on CT: a low attenuation plaque of less than 30 HU with a soft core, napkin ring shine with a bright rim around the center, positive remodeling with outward bulging, and spotty calcification. Now, I found diabetics had 2 times more higher CSE and nearly double the calcium burden. Triple vessel disease was 7 times higher in diabetics. Mixed plaques were 3 times more common, and low attenuation plaques were 1.5 to 2x times more common. Diabetics showed far more moderate severe stenosis, especially in LAD, which was 36% versus 0% in non-diabetics. Normal LAD segments were much fewer, 48% versus 90%, and hypertension and diabetes produced the highest CSE, that is 317.89. Now our results are align well with the literature, and first Raggi et al. Demonstrated that in diabetics the plaques are more extensive, multivessel, and further it was elaborated by Maffei and Chu that diabetics had increased non-calcified and mixed plaques, and diabetics are 3 times more prone for vulnerable plaques. Now, diabetes mellitus is a strong independent predictor of coronary calcification. Diabetes is associated with higher calcium burden, diffuse multivessel disease, and more vulnerable plaque patterns. CTCA with calcium scoring is a powerful non-invasive tool for early detection and risk stratification in diabetic CAD. Thank you.
Thank you so much, Dr. Siddhant. Next, I would like to call upon Dr. Shakti Prasad Panigrahi.
Good morning, Doctor. Role of triple phase MDCT in evaluation and characterization of focal hepatic lesions with clinico-pathological correlation. So aim is to evaluate the diagnostic role of triple phase MDCT in characterizing the focal hepatic lesions based on their enhancement patterns. It's a prospective cross-sectional study of 75 patients with hepatic lesions detected clinically on USG with a scanner of 128/MDCT. The phases are non-contrast arterial phase, which is taken around 25 to 30 seconds after post-injection. Portofenol 60 to 70 seconds post-injection, delayed 3 to 5 minutes. The contrast is ioaxial and histopathologically correlated. Enhancement pattern of hepatocellular carcinoma is arterial phase hyperenhancement with portal and delayed phase washout. In hemangioma, there is peripheral nodular enhancement in arterial phase with centripetal filling in portal and delayed phases. In abscess, there is peripheral rim enhancement with central hypodensity. In FNS, there is arterial centrifugal enhancement with sustained enhancement on portovenous phases with persistent scar enhancement on delayed phases. And metastasis, there is variable enhancement as most of the metastases appear hypoenhancing in all phases, with the rim and target enhancement commonly seen in arterial phases due to viable tumor in periphery. But most of the hypervascular metastasis, like from NET, RCC, melanoma, thyroid, and sarcoma, shows arterial hyperenhancement with washout and persistent enhancement. On results, the lesion distribution out of total 75 patients, the most common being metastasis comprising of 43%, followed by hemangioma 22%, then HCC 14.3%. Percentage distribution of focal hepatic cells according to age. Overall, the most common malignant focal lesion was metastasis, accounting for 42%. The primary malignant lesion is HCC, accounting for 14.3%. Metastasis were seen in around 50 to 59 years, and 50% cases of the HCC were seen in 60 to 70 years. There is male preponderance in HCC, intrahepatic cholangiocarcinoma, and metastasis when compared to females, and all cases of FNH, hydatid cyst, and most of the hemangioma are seen in females. Distribution of benign or malignant hypovascular focal lesions. Most of the hypovascular focal lesions are cyst, 31%, and followed by metastasis. And out of hypervascular focal lesions, the most common is hemangioma, 49%, followed by metastasis, 30%. This is the graph showing enhancement pattern and percentage correlation with final diagnosis of hypervascular lesions. And this is the enhancement pattern and a percentage correlation with final diagnosis of hypervascular lesions. So discussion is triple phase MDCT provides excellent dynamic and contrast enhancement assessment for the focal hepatic lesions. Arterial, portovenous and delayed phases help reliably differentiate vascular, benign and malignant lesions. HCC typically shows arterial hyperenhancement with delayed washout, and hemangiomas display a classic peripheral nodular enhancement with centripetal filling in and enabling diagnosis. Metastasis remain the most common lesion. Triple phase imaging helps in identify variable enhancement based on the primary origin, and cholangiocarcinoma and other atypical lesions demonstrate delayed progressive enhancement in differentiation. So the limitations are small lesions which are less than 1 centimeter are difficult to characterize due to limited spatial resolution, overlap in enhancement patterns, typically in metastasis cases, radiation exposure, contrast related issues. Hypervascular tumors may appear similar to benign lesions in early phases, and there is limitation in detecting early cirrhotic nodules in case of MRI. Conclusion is triple phase MDCT is highly accurate and rapid tool for evaluating focal hepatic lesions. Dynamic enhancement patterns allow confident differentiation of benign versus malignant lesions, shows strong correlation with clinicopathological findings, improving diagnostic certainty, highly useful in treatment planning, serves as a key first-line imaging modality, and integrating with clinical history and laboratory data, there is enhances the diagnostic precision. So overall, triple phase MDCT should remain a cornerstone modality in hepatic lesion evaluation. Thank you.
Thank you, Dr. Shakti. Next is Dr. Prasanna Bikas Sahu.
Good afternoon, everybody. My topic is evaluation of the role of MRI in spinal trauma and correlation of the imaging finding with clinical profile according to the ASIA impairment scale. Traumatic spinal cord injury causes lifelong motor, sensory, and autonomic dysfunction. Motor vehicle accidents are major causes. Early diagnosis and timely management are essential. MRI is the gold standard, which detects fracture, ligament injury, disc prolapse, canal stenosis, and cord changes. MRI findings help in predict severity and recovery. Advanced MRI imaging, DWI, and functional MRI support evolving SCI treatments. My aims and objectives of the study will be to evaluate the role of the MRI in spinal trauma and correlation of the imaging findings with clinical profile according to the ASIA, that is American Spinal Injury Association impairment scale. Secondarily, to study the MRI findings in the patients with acute spinal trauma and to correlate the MRI findings with clinical profile and neurological outcome. So my methodology will be it is a hospital-based cross-sectional study with including 160 patients in the Department of Diagnosis in IMS and some hospital Bhubaneswar for a duration of 12 months. So the inclusion criteria, all the patients with acute spinal trauma with clinical stability, and the exclusion criteria will be post-operative patients, uncooperative patients, patients with contraindication to MRI or past spinal conditions will be excluded from the study. So this is the ASIA chart they follow, the neurosurgeons and the physicians which usually they follow to grade the different stages of ASIA impairment scale. So there are 5 grades, A, B, and C, and D. A is complete injury, where there is no motor function in S4 and S5, no sensory function in S4 and S5. Then grade B is sensory incomplete, where there is no motor function below the level, including S4. Sensory function is preserved in S4 and S5. In grade C, motor incomplete, motor function is preserved in more than 50% muscles below the level, and the power is less than grade 3. A sensory function may or may not be intact. Grade D is motor incomplete, motor function is preserved in more than equal to 50% of the muscles below the level, and the grade of the power grade will be more than equal to 3. Sensory function may or may not be intact. E is normal motor function and normal sensory function. So this is a case, 55-year-old male who came with a history of spinal injury. The spinal cord at C2 and to C7 level shows T2 hyperintense intrinsic signal with evidence of blooming on medic sequences at C3 to C5 level, suggestive of hemorrhagic cord contusion. This is another case, 53-year-old male with the same similar spinal trauma injury, where the MRI findings are right unilateral facet dislocation at the level of C5, C6 with resultant grade 1 enterolisthesis of C5 over C6 with annular tear leading to disc extrusion causing mild to moderate spinal canal stenosis and impingement of the spinal cord with T2 stirred hyperintense signals showing blooming on medic sequences suggestive of cord contusion. So there is slight rotation of C5 vertebra to the left and rupture of ligamentum flavum as well. So another case, 54-year-old male came with a history of spinal trauma. The spinal cord shows altered its signal intensity, appearing hyperintense on T2 and blooming on hemosequence with cord expansion at C5 to C7 levels, suggestive of acute cord contusion. T2 star hypertension noticed along the spinous process of C3 vertebra, suggestive of bone marrow edema due to underlying fracture. Fracture noted involving the right occipital condyle, which is confirmed on CT. Grade 1 retrolisthesis of C3 over C7 vertebra without spondylolysis. The prevertebral hemorrhage collection and star hypertension noted in posterior paraspinal muscles and subcutaneous tissue, suggestive of edema. Another case, a 49-year-old male came with a history of spinal trauma. MRI shows fracture of supraarticular facet of C5 and infraarticular facets of C4 with resultant facetal dislocation of C4 over C5 and grade 3 anteriolisthesis of C4 over C5 vertebra is noted. Disruption of anterior longitudinal ligament, posterior longitudinal ligament and ligamentum flavum are noted at the level of C4 and C5. Interspinous and supraspinous ligament also show mild injury with loss of continuity at C4 and C5 level. Muscle edema is noted in bilateral paraspinal injury extending from C3 to C6 level. Compression of spinal cord which shows cord expansion. Hyperintense signal of T2 from C3 to C6 level, suggestive of acute cord contusion. So there is altered area of hyperintensity in T2 at the level of C4, C5, suggestive of hemorrhagic foci. So the resultant conclusion will be the mean age which is most commonly affected is 40 plus minus 18 years. Age group most commonly the young age, which is 26 to 45 years old. Largest group males are mainly affected and mostly it occurs in urban areas. And most common area spinal region affected is cervical spine, and cord compression is present in 32.8% cases. The MRI findings suggest that at admission the ASIA score is almost ASIA A, that is complete injury, and at discharge either it is stays as ASIA A or at D. So the MRI findings and correlation will be most common abnormality will be cord trauma and contusion, which is more than 3 centimeter in 44.8 cases. The cord hemorrhage is most commonly ASIA A with minimal improvement, edema and contusion. There is slight motor improvement. Outcomes will be neurological improvement in 20%, but there is strong correlation between MRI abnormality versus neurological outcome. So MRI is the gold standard of imaging modality in SCI, evaluates vertebral fractures, event injuries and disc prolapse, spinal canal narrowing and cord compression, cord edema, hemorrhage, everything is and helps to determine the level and severity of injury, guides clinical and decision making and surgical planning. Thank you.
Thank you, Dr. Prasann. Next, we have Dr. T.K. Krutish.
Yes. Good morning to one and all present here. Myself, Dr. T.K. Krutish. Today, I am going to present a paper on role of quantitative T2 mapping MRI in early detection of cartilage injury in the knee joint. The aim of the study is to evaluate the role of quantitative T2 mapping MRI in detecting early biochemical cartilage injury before morphological changes appear on routine MRI, and to compare diagnostic performance of T2 mapping and conventional MRI in assessing knee joint integrity. Introduction. Articular cartilage is smooth, avascular, aneural, and has a limited regenerative capacity. Early injury leads to biochemical changes, and which finally leads to osteoarthritis. Conventional MRI detects only morphological changes while T2 mapping quantifies collagen integrity and water content for early detection. It helps in early diagnosis, prevention, treatment, and monitoring osteoarthritis. Coming to materials and methods, an observational study from April 2025 to October 2025 was conducted with a sample size of 25 patients, which includes 15 males and 10 females with a mean age of 36.8 years. And it was conducted in Department of Radiology, MKCG Medical College, Berhampur, Odisha. And data collection was done with the help of MRI 1.5 Tesla Philips system with PD, T2 weighted and T2 mapping, multi-echo spin-echo sequences. Understanding T2 mapping technique, multi-echo spin-echo sequence with echo time from 10 milliseconds to 80 milliseconds and repetition time from 1 to 1.5 seconds is used, and pixel-wise exponential fitting of signal intensity is done, which gives a color-coded T2 map with a specific T2 relaxation values. These T2 values reflect the microscopic integrity of the cartilage, specifically the degree of collagen fiber, organization, and water mobility. In T2 mapping, each voxel gets its own color based on its T2 value. So for every pixel or voxel, the scanner plots signal versus TE and fits an exponential decay curve. So signal intensity measured at a specific echo time is given by initial signal intensity times the e to the power of negative TE over T2. This equation describes how the MR signal decays exponentially with increasing echo time. Each voxel is assigned a color based on its T2 relaxation time. So here in low T2, it is given by blue or green color signal intensity, which implies healthy cartilage. And high T2 levels is given by yellow or red color signal, which implies injured cartilage. So result overview, 25 patients with a mean age of 36.8 years, with left knee having 56% and right knee 44%, and conventional MRI detected morphological defects in 40% of the cases, while T2 mapping detected biochemical alteration in 68% of the cases. The mean T2 value of normal cartilage was 38.4 milliseconds, while biochemically degenerated cartilage was 50 milliseconds, and morphologically defective cartilage was 58 milliseconds. And with the ROC cutoff of 45.8 milliseconds, we achieved a 96% sensitivity and 92% specificity with an area under curve of 0.91, showing excellent diagnostic accuracy. So coming to representative images, this is the case of 18-year-old male patient who came with the history of sports injury. So the first row shows the conventional MRI images where the cartilage is normal, and the second and the third row shows the T2 mapping technique. So here we can see it shows the blue signal intensity, and only in the medial cartilage we can see a slight red signal intensity, which shows the degenerated cartilage. And there is another case. This is the case of 26-year-old male patient with history of twisting on right knee. And here we can see the conventional MRI shows normal cartilage and there is no cartilage disruption, while on T2 mapping we can see red signal and yellow signal, which implies cartilage disruption, which can further lead on to osteoarthritic changes. So coming to discussion, T2 mapping detects early biochemical changes unseen on standard MRI sequence. The elevated T2 values indicate collagen disorganization and increase in hydration. It is a quantitative, non-invasive biomarker for early cartilage injury. The emergence of cartilage resurfacing procedures and disease-modifying therapies for osteoarthritis highlights the need for non-invasive imaging techniques like T2 mapping to detect early degeneration and monitoring disease progression and assess treatment response. Finally, I like to conclude that quantitative T2 mapping MRI is a sensitive and reproducible technique which detects biochemical cartilage changes before morphologic defects. And with the sensitivity of 96% and specificity of 92% and area under curve of 0.91, which shows excellent diagnostic accuracy. It is a valuable adjunct to MRI for early diagnosis grading and monitoring of cartilage injury. These are my references. Thank you.
Thank you, Dr. TK. Next is Dr. Abhijit Satapathy.
So good afternoon, everyone. My study is MRI quantification of hippocampal volume in patient of temporal lobe epilepsy. The study was done in MKCJ Medical College. So aim of my study was to calculate the hippocampal volume of a patient with temporal lobe epilepsy and compare them with the normal population. To correlate the lateralization of the epileptic focus determined by volumetric analysis with EEG findings. So introduction was temporal lobe epilepsy is the most common type of focal epilepsy syndrome with often characteristic imaging and clinical findings. There is two types, the medial epilepsy and lateral epilepsy. So medial epilepsy is most common type and involve the mesial temporal lobe structures most frequently due to mesial temporal sclerosis. And lateral involves the inferolateral and lateral neocortex of the temporal lobe. So this is the normal anatomy taken in T1 inversion recovery in coronal view. So you can find the hippocampus here, and this is the normal anatomy of the hippocampus. This is the parahippocampal gyrus, this is the subiculum, and this is the C1, 2, 3, and 4, and this is the dentate gyrus. So my materials and methods are the total sample I have taken 75, number of patients 50 of cases, and control normal patient 25. So patients suspected with temporal lobe epilepsy by clinical and EEG criteria were referred for MRI brain to the Department of Radiodiagnosis in MKCJ MCS. So type of my study was observational study, and place of study MKCJ Medical College. So this is the normal 3D volume of a hippocampus. The volume found at 3651 cubic millimeter. So this is a hippocampal atrophic volumetric analysis. So in unilateral hippocampal sclerosis, the volume found at 1043, and in bilateral, the right side volume was 2339, and the left side there is 2420 in a temporal lobe epileptic patient. The age of distribution was 28 years plus or minus 6 years. The standard deviation was 6.4, and the studies, the age distribution was like this. In the gender distribution, in cases, there is 17 cases are female and 33 were male, and in controls, the 10 was female and 15 were male. So mean hippocampal volume and statistical significance. So normal population, the left side was 3.3 cc and the right side was 3.2 cc. In medial lobe temporal lobe epilepsy, the left side was 2.5 and the right side 2.4. The volume, the variance of the population, the left side was 11 and right side was 10.2, and the p-value of the left side was 0.04 and the p-value of the right side was 0.042. After calculating all the things, the value of the Z was minus 1.723 and the p-value was 0.04. The result is significant at less than 0.05 p-value. And this is the p-value of minus 1.72. So comparison among the sites of the hippocampal sclerosis and corroboration with the EEG, the patient with hippocampal sclerosis, only left side affected 34 patients and right side was 11 patients, and both side was affected by 5 patients. Left side was affected in a majority of cases, that is 68%. The side of the epileptic focus as determined by EEG and the side of the hippocampal sclerosis on MRI was corroborative with in 40 out of 50 cases, that is 80%. So comes to the conclusion, hippocampal sclerosis is a major cause in patient with temporal lobe epilepsy. Hippocampal volume calculation can be useful in cases of subtle hippocampal sclerosis. So medial temporal lobe epilepsy, hippocampal sclerosis can be diagnosed in most cases, and radiology plays a pivotal role in this. So surgical treatment is possible in most of the cases. Hence, early diagnosis can be very helpful in decreasing the morbidity of the patient with temporal lobe epilepsy. So these are my references. Thank you.
How you calculated, how you segmented the hippocampus? It's manual segmentation or by any software?
No, ma'am, manual segmentation.
Okay, and in mesial temporal lobe sclerosis, have you taken other features into account like hyperintensity and other secondary
No, ma'am, only volume I
features?
have taken because the patients referred to us were found in temporal lobe epilepsy in EEG or any clinical diagnosis first done. Then they were sent for MRI.
Okay, and have you taken into account acute and chronic MTS?
No,
MTLA?
ma'am.
No. Okay.
Thank you, ma'am.
Thank you, Dr. Abhijit. Next, we have Dr. Swaleha.
A very good afternoon to respected faculties and my colleagues. Today I'd like to present a topic, role of shear wave elastography for assessment of placental stiffness in fetal growth restriction. Fetal growth restriction is a common complication of pregnancy and a leading cause of stillbirth and perinatal morbidity as well as mortality worldwide. Perturbations in uteroplacental circulation and placental dysfunction are the key factors in the etiology of FGR and preeclampsia. Placenta from pregnancies complicated by FGR show characteristic macro and microscopic histopathological abnormalities like ischemic and hemorrhagic infarctions, fibrosis, and parenchymal hemorrhages, which are reflective of maternal vascular malperfusion and hypoxia-induced insult to the placental villus tree. Shear wave elastography as a non-invasive and reproducible marker of tissue inflammation and disease can be used to assess the severity of fibrosis and inflammation in various tissues, and this technique has recently been applied to assessing the biomechanical properties of placenta. The study aims to quantify placental stiffness on shear wave elastography and analyze its relationship with FGR staging and gestational age alongside our conventional Doppler findings. So you might ask me, what is the need for our study? Well, there have been limited studies that correlate shear wave elastography values with the stages of FGR. It could aid in early detection and could guide closer monitoring and timely delivery, and could also serve as an objective and quantifiable marker. So this study that we concluded was a clinical cross-sectional analytical hospital-based study at the Department of Radiology, IMS and Some Hospital, Bhubaneswar, where we took patients that were referred to us for obtaining obstetric ultrasound scans, and after due consent was obtained, we took about 120 pregnant women from 28 to 36 weeks of gestation who underwent obstetric fetal biometry and Doppler assessment with shear wave elastography assessment as follows. So all the patients that were 28 to 36 weeks were included in the study who consented to us, and they were allocated two groups. Group A was the FGR group, which were about 60 patients, and the group B was normal pregnancies. They were both subjected to normal obstetric ultrasound of Doppler evaluation as well as fetal biometry, and as well we required ultrasound shear wave elastography values on a Samsung V8 model. So this is a visual representation of how we acquired the shear wave values. Let's take a brief review at what are the Barcelona guidelines of FGR. So the stage 1 is where the estimated fetal weight is less than 3rd percentile, or if it is less than 10th percentile but the MCA-PI values are less than 5th percentile. Stage 2 is if the fetal weight is less than 10th percentile with an absent end-diastolic flow of umbilical artery. Stage 3 is with reversal of end-diastolic flow of umbilical artery, and stage 4 is with the reversal of flow of the ductus venosus. So the results we concluded was that the placental stiffness as measured by the shear wave elastography differed significantly between the FGR category and the control category. The mean placental stiffness in the FGR category was about 3.5 kilopascals plus minus 0.8, and in the control category was 2.1 kilopascals plus minus 0.6, which suggests that the FGR placenta is significantly stiffer. We also observed that the placental shear wave elastography has showed a negative association with birth weight percentile, which suggests that a higher stiffness correlates with poorer growth of the baby, and it also has a positive association with the umbilical artery PI, which suggests that higher stiffness of placenta was correlating with an increased vascular resistance. So higher placental stiffness reflects the worsening placental insufficiency and also correlates with both reduced fetal growth and abnormal Doppler findings. This is a visual representation of the same data that I've discussed in the results. I'd like to conclude by saying that shear wave elastography can be used as an early identification of FGR. It has a good clinical application value and has research prospects in obstetrics. It is also objective and repeatable quantitative operation, which will be helpful in providing information on placental dysfunction as in preeclampsia and fetal growth restriction. It has a role in predicting the adverse perinatal outcomes on a prospective basis and will definitely aid as a supplementary tool along with regular obstetric grayscale and Doppler studies. These are my references. Thank you. Thank you.
Thank you, Dr. Soleha. Next, we have Dr. Daksh.
Good afternoon, everyone. My topic is diagnostic utility of shear wave elastography in Achilles tendinopathy. Achilles tendinopathy is a prevalent musculoskeletal disorder affecting both athletic and general population characterized by pain, swelling and impaired function due to collagen disorganization and biomechanical alterations. Traditional imaging B-mode ultrasound MRI primarily visualizes structural morphology but provides limited functional assessment of tendon mechanical properties, creating a diagnostic gap in managing tendinopathy. Shear wave elastography represents a significant advancement in musculoskeletal imaging, providing quantitative measurement of tissue stiffness by measuring shear wave propagation velocity through tendon tissue. Clinical rationale. Shear wave elastography addresses critical limitation of conventional imaging by detecting early biomechanical changes before structural damage becomes apparent, enabling objective monitoring of treatment response and rehabilitation progress. Aim and objectives to comprehensively evaluate the reliability, validity and responsiveness of shear wave elastography in assessing Achilles tendinopathy, establishing its role as a quantitative biomarker for tendon health. Objectives to establish standardized protocol for shear wave elastography acquisitions in Achilles tendons. Assessment include patient positioning, transducer placement and measurement technique. To investigate the correlation between shear wave elastography values and clinical parameters such as pain scores, functional scale, and treatment outcomes, to assess the cost effectiveness and overall clinical utility of shear wave elastography. Material and methods. Is study design is prospective cross-sectional study conducted in Department of Radiodiagnosis IMS and some hospital Bhubaneswar for a 12-month duration. A total 60 participants were included, 18 male and 12 female as cases, and in control 11 males and 19 females. Inclusion criteria: adult aged more than 18 years with unilateral or bilateral Achilles tendon pain, stiffness or functional impairment, Achilles tendinopathy diagnosed clinically or via imaging, no prior Achilles tendon surgery, no corticosteroid injection within the affected site within 6 months. Exclusion criteria: acute tendon rupture or full thickness tear, systemic inflammatory diseases, systemic corticosteroid use in the last 6 weeks, several ankle joint deformities or restricted motion. Ultrasound examination equipment: high resolution linear transducer used, B mode ultrasound used to assess tendon thickness, ecotexture and structure. Power Doppler assessed vascularity in tendon and peritendinous tissue. Shear wave elastography conducted in the longitudinal plane with the ankle in neutral position. Region of interest placed at the mid portion of Achilles tendon. Each tendon evaluated with quantitative shear wave values in kilopascals and meter per second. Semi-quantitative color mapping done. Tendon classified as soft, intermediate, rigid based on color, that is blue, green, yellow, orange or red respectively. 3 consecutive readings were taken per tendon and the average was used for analysis. Case 1, early Achilles tendinopathy. A 45-year-old recreational runner with 4-month history of gradual onset mid-portion Achilles pain. Pain worsened during initial weight bearing, after rest and during running activities. VISA A score 65 by 100 indicating moderate functional limitation. Physical examination: localized tenderness 3 to 5 cm proximal to insertion, mild thickening. Imaging findings: B mode ultrasound, minimal fusiform thickening of the Achilles tendon, AP diameter measuring 7.2 mm with subtle hypoechoic areas but maintained fibrillar pattern. Power Doppler: minimal increased vascularity at the proximal aspect of the lesion. Shear wave elastography significantly reduced stiffness value. Case result and interpretation: SWE detected early functional impairment not fully apparent on conventional B-mode imaging, reduced stiffness value consistent with collagen disorganization and edema in early tendinopathy. Clinical correlation: SWE findings explain disproportionate pain compared to mild structural changes. Management impact: SWE guided modified rehabilitation protocol focusing on eccentric loading with real-time stiffness monitoring. Case 2, advanced chronic tendinopathy. Clinical presentation, 58-year-old male construction worker with 18-month history of progressive Achilles pain. Failed extensive conservative treatment including physical therapy, extracorporeal shock wave therapy. Significant functional impairment with difficulty in climbing ladders and prolonged standing. VISA score came out to be 42 by 100, indicating severe functional limitation. On imaging findings, B-mode ultrasound marked tendon thickening, AP diameter measuring 10.5 mm, heterogeneous ecotexture with scattered hypoechoic region, dissociated fibrillar pattern, power Doppler, moderate to marked neovascularization through the diseased tendon segment. Shear wave elastography showed marked reduction in stiffness. Case result and interpretation. SWE confirmed advanced degenerative changes with correlation between structural and functional impairment. Extremely low stiffness value indicated significant loss of tendon resilience and high injury risk. Monitoring application. SWE provided objective baseline for evaluating treatment response during regenerative therapies. Surgical planning. SWE finding help identify tendon quality at surgical margin for potential repair. Result. Quantitative SWE findings, mean stiffness in cases came out to be 52 kilopascal, whereas in control it was 305 kilopascal. Interpretation, tendinopathic tendon shows more than 6-fold reduction in stiffness. Mean shear wave elasto velocity in cases was 2.8 milli per second, whereas in control it was 8.3 milli per second. Interpretation, reduced SWE reflects impaired mechanical integrity. Tendon thickness in cases average was 7.6 mm, whereas in control it was came out to be 5.5 mm. Interpretation, consistent with clinical thickening and tendinopathy. Technical consideration, standardized protocols are essential. Specific patient positioning, prone with feet hanging relaxed, consistent measurement location, and adequate transducer gel with minimal compression improve reliability. Multiple acquisition should be taken. Achilles tendon stiffness varies by anatomical portion, tension state, individual factors. To conclude, SWE provides a reliable quantitative assessment of Achilles tendon stiffness with good to excellent inter-observer agreement when standardized protocols are used. SWE demonstrates superior sensitivity for detecting early tendinopathic changes compared to conventional ultrasound with increased diagnostic accuracy from 89 to approx 98% when combined with B-mode imaging. SWE enables functional monitoring of treatment response showing significant stiffness changes corresponding to clinical improvement that may not be apparent on structural imaging. These are my references. Thank you.
Thank you, Dr. Daksh. Next, we have Dr. Satyajit.
So, good afternoon, judges. My paper presentation is on role of CCT in evaluation of laryngeal lesions with clinicopathological correlation. Aims and objective is to detect, to determine diagnostic accuracy of CT to detect and characterize laryngeal masses with endoscopic and pathological findings, and staging of carcinoma larynx with clinicopathological correlation. Introduction and background. Benign laryngeal lesions commonly cause dysphonia and may result from inflammation, infections, trauma, or voice abuse, while malignant laryngeal lesions constitute around 25% of head and neck cancers, 95% being squamous cell carcinoma, and predominantly in males aged from 50 to 70 years. Major risk factor being tobacco, alcohol consumption, GRD, HPV infection, radiation, occupational exposure. Hence, accurate diagnosis and staging is crucial. CT and MRI plays a significant role in lesional extension, cartilage invasion, and TNM staging. So, material and method, this is an ambidextrous observational analytical study of comprising of 62 cases as per the inclusion and exclusion criteria over a period of 3 years conducted at the Department of Radiodiagnosis, Pathology and ENT SCB Cuttack. Inclusion criteria included patients with newly diagnosed laryngeal masses, either clinically, laryngoscopically or biopsy proven, which were referred to our department for CCT. Exclusion criteria include patients who had received any form of chemo or radiotherapy or surgery. Any traumatic, neurologic or neurogenic or congenital lesions are excluded. Lesions from pharynx or hypopharynx extending to larynx are excluded, and patients lost in follow-up, and patient who didn't give consent. So, CT protocol, the CT was done on G revolution maxima 120 slice. The patient was in supine position, shallow breathing, no swallowing or coughing. Parallel cuts were taken parallel to the true vocal cord and ventricle from skull base to thoracic inlet with a 60 to 80 second delay. The CT findings were analyzed in order to stage and to detect operability as per the following: epicenter being the supraglottic, glottic or subglottic, transglottic spread, pre-epiglottic and paraglottic space invasion, retroglottic cord involvement, involvement of pyriform sinus, valvula base of tongue, extralaryngeal spread like involvement of esophagus, trachea, thyroid, strap muscles, carotids and IJV, cartilage invasion. Contraindication to voice preservation surgery included involvement of the intra and extralaryngeal cartilages with involvement of pyriform sinus, base of tongue and extralaryngeal spread. So our results were majority of the in our study it showed a male predominance of 8:2 with female, and the mean population was 41 to 60, and 78% of the cases had a history of alcohol or tobacco use. So in this table we can see we had a maximum amount of malignant cases around 45, inflammatory were around 12, and benign cases were around 8. In laryngeal involvement, supraglottic was the largest subset, with transglottic being the least. In transglottic, we had 2 lesions, one from the subglottic extending to glottic, and a supraglottic lesion extending to glottic. This was the CT staging. Here actually you can see the most supraglottic patients present in later stage, that is T3 or T4, maybe due to milder symptoms, while the patients of glottic and subglottic presented early at T1 or T2 stage. And in end staging, there was significant nodal mass present in case of supraglottic, while one case in glottic showed a N1 nodal mass, and there was no nodal mass in case of subglottic CS. In this table, we can see how CT accurately stages CT accuracy as compared to pathological T staging. Here we can see the CT has accurately around 82% accuracy as compared to clinical pathological correlation in case of supraglottic, 90% in glottic, and subglottic up almost like 100%. In this, here we can see a right vocal cord nodule in between anterior 2/3 and posterior 1/3 of the right vocal cord. This is a T3 right true vocal cord mass with causing sclerosis of the right IT node. This was an inflammatory case with bilateral symmetrical and thickened edematous epiglottis and ariepiglottic fold. This was a T4 supraglottic mass involving ariepiglottic fold with pyriform sinus involvement and erosion of the thyroid lamina, and level 3 nodal mass. And these were the, these were the 10x and the 40x magnification of SCC with keratin pulse. So in discussion, around 60 out of 62 cases, only 25 underwent surgery. Supraglottic was the maximum subset, and CT accurately staged around 88% of cases as compared to histopathology. And CT also showed 100% sensitivity in all the supraglottic, glottic, and subglottic subset, with 67% specificity in supraglottic, 90% in glottic, and 100% in subglottic. Cartilage involvement in form of sclerosis, cortical erosion, and breach were better appreciated on CT. Limitation was it was very difficult to assess reactive sclerosis from early erosions, and paraglottic fat sending due to edema, infection, or tumor cause overestimation of T3. T3 may be underestimated due to inability to detect early cartilage invasion and paraglottic involvement. Conclusion was CT remains a reliable modality for initial T and N staging. Frank cartilage involvement was better appreciated on CT. CT did a good job in accurately staging T4 supraglottic, glottic, and subglottic lesions, with exception in T3, T4 staging, where it can be complemented with MRI for better radiological staging. These were my references. Thank you.
Thank you, Dr. Satyajit. Next, we have Dr. Gitanjali.
Good afternoon, everyone. My topic is role of MR imaging in evaluation of carcinoma cervix with phygostaging and clinicopathological correlation. Introduction and background. Cervical cancer is the 4th most common cancer globally and 3rd in India, strongly linked to HPV infection. Histopathological examination is the gold standard for diagnosis, and squamous cell carcinoma being the most common type. MRI is a non-invasive, radiation-free modality offering superior soft tissue contrast for evaluating tumor size, extent of invasion into surrounding tissues, and nodal or distant metastasis. FIGO 2018 staging integrates imaging findings, improving accuracy over the 2009 clinical-only system, guiding precise treatment planning. These are my aims and objectives: to determine MR imaging characteristics of carcinoma cervix in newly diagnosed patients, to evaluate the efficacy of MRI in assessment of important prognostic factors in carcinoma cervix like tumor size, involvement of parametrium, pelvic sidewall, and adjacent organs along with nodal status, to correlate MRI staging with clinical staging in patients of carcinoma cervix and histopathological findings wherever possible in operable cases. Materials and methods. Case selection. This is an observational analytical study consisting of 70 females selected as per inclusion and exclusion criteria over 2 years, conducted in Department of Gynecological Oncology in Acharya Haria Regional Cancer Center, Cuttack, and Department of Radiodiagnosis and SCB Medical College, Cuttack. Our inclusion criteria include patients with newly diagnosed clinically or biopsy-proven carcinoma cervix referred for MRI, and exclusion criteria are patients who have received any form of chemo or radiotherapy and patients not fit for MRI study due to cardiac pacemakers, metallic implants, and claustrophobic patients. MRI protocol. MRI examinations performed on a 1.5 Tesla scanner. Dual channel body array coils used for all examinations. Patients instructed to fast for 4 hours prior to scan to reduce bowel peristalsis artifacts. These are the sequences we have used, and the parameters assessed are tumor size, site, and margins, signal characteristics on various sequences, tumor enhancement pattern, extension into vagina and lower uterine body, parametrial or pelvic sidewall involvement, urinary bladder or rectal wall invasion, presence of hydroureteronephrosis, and lymph node involvement. Our observation and results. So the most common chief complaint in carcinoma cervix being postmenopausal bleeding, followed by foul-smelling discharge, positive association between carcinoma cervix and multiparity and HPV positive status seen, and the most common histopathological type of carcinoma cervix we found non-keratinizing type of squamous cell carcinoma. These are the patients staged according to clinical FIGO staging and MRI FIGO staging, and the lower graph showing correlation of clinical FIGO staging with MR FIGO staging. Out of 70 patients, 44 were staged accurately. There is mild to moderate correlation between clinical and MRI FIGO staging, with 22 patients being upstaged on MRI and 4 patients were downstaged on MRI. Table and graph showing correlation of MRI FIGO staging with histopathological finding. MRI accurately staged 79.16% of patients, understaged 12.5% of patients, and overstaged 8.3% of patients. Discussion. 70 patients were evaluated. 24 underwent surgery for histopathological correlation. MRI FIGO staging showed 79.16% overall accuracy versus histopathology, understaging in 12.5% patients and overstaging 8.3% of cases. Stage 1B1 and 1B3 showed 100% accuracy, and 1B2 87.5% accuracy. High negative predictive value for parametrial invasion, aiding distinction of stage 2A versus stage 2B. And in lymph node detection, the sensitivity is 65% and specificity is 67% due to size-based limits. DWI enhances nodal detection, but false positives remain a challenge. Bladder and rectal invasion, sensitivity 82% and specificity 84%, consistent with Rikak et al. MRI provides excellent soft tissue contrast, accurately assessing tumor size, stromal invasion, and local extent for treatment planning. These are our images. Stage 1, first one showing stage 1B, T2 hyperintense lesion confined to cervix. Stage 2B, T2 hyperintense lesion showing parametrial involvement on right side. Stage 2A, T2 hyperintense lesion from anterior lip of cervix extending to upper 2/3 of vagina. Stage 3A, lesion extending to lower 1/3 of vagina. Stage 3B, parametrial involvement with left side hydroureteronephrosis. Stage 3C, bilateral enlarged internal and external iliac nodes. Stage 4A, involvement of posterior wall of bladder. And histopathological types of carcinoma cervix, right one showing well-differentiated adenocarcinoma, and left one squamous cell carcinoma keratinizing type. Limitations. MRI failed to detect lesions less than 5 mm due to limited spatial resolution, overestimation of upper vaginal involvement seen in 2 cases, likely from adjacent inflammation or edema. MRI unable to detect reactive versus malignant lymph nodes. Normal morphology doesn't exclude metastasis. Para-aortic 3C2 and distant metastasis 4B excluded due to limited field of view. No correlation found between tumor differentiation and disease stage. Conclusion. MRI plays a pivotal role in accurate staging and management of cervical cancer, especially with FIGO 2018 classification. MRI most accurate in staging 1B and 2A lesions, effectively assessing tumor size, local invasion, and nodal status. Integration of MRI enhances prognostic assessment, fertility-sparing decisions, and treatment planning in advanced diseases. Advanced imaging techniques like dynamic contrast enhanced MRI, DTI, PET MRI, and quantitative ADC mapping may further improve tumor characterization and personalized therapy. These are my references. Thank you.
Thank you, Dr. Gitanjali. Next, we have Dr. Shakti.
Good afternoon to all. Today my topic is role of MR imaging in preoperative assessment of anorectal fistula. Aims and objective: assessment of diagnostic accuracy of MRI in detecting anorectal fistula, identifying the type, location, extent of anorectal fistula, and involvement of anal sphincters. To assess the role of MR in identification of secondary tracts and abscess, assess how MR findings impact the surgical decision making. Introduction: anorectal fistula is an abnormal tract between the anal canal and perianal skin, causing pain, discharge, and recurrent infection. It often follows perianal abscess or condition like Crohn's disease, tuberculosis. Accurate perioperative assessment is essential. MRI with superior soft tissue resolution is the gold standard for delineating tracts and abscess, guiding surgery and reducing the recurrence. Materials and methods. Data for the study has been collected from the patients attending the Department of Radiodiagnosis, SCB Medical College, being referred primarily from the General Surgery Department. It is a type of prospective study on 72 patients with anorectal fistula, which is conducted over for a period of 2 years. Inclusion criteria: adults who have clinically diagnosed with the perianal fistula. Exclusion criteria: patient with history of TB, Crohn's disease, or previous history of surgery and radiation. If patient is non-cooperative and does not give consent, patient with perianal sinus, and if there is contradiction for MRI. MRI protocol: MRI examination was performed on 1.5 Tesla using phased array surface coil with 6 channels. No patient preparation is required, and the patients are placed flat on their back. Pre-construct image will be obtained as follows: sagittal T2 image and oblique coronal fat saturated image, oblique axial T2, oblique axial fat saturated, oblique axial T1, and axial fat saturated. After an intravenous administration of gadolinium, post-contrast fat saturated T1 image were acquired in 3 planes, that is sagittal, coronal, and axial. Then primary tracts in relation with the internal anal sphincter and external anal sphincter and levator ani muscle, that is length, course, and Park classification according to the ST James grading. Internal opening, that is clock position, height from anal verge. Secondary tracts relation with the internal anal sphincter and external anal sphincter, length and internal opening. Abscess formation, that is relation with the internal anal sphincter, external anal sphincter, diameter and shape. Condition of the internal anal sphincter and external anal sphincter, that is scarred or atrophied or hypertrophied. Fistula were classified according to the Parkes grading. There are 5 grades, that is grade 1, grade 2, grade 3, grade 4, grade 5. Grade 1 is intersphincteric fistula, grade 2 is intersphincteric fistula plus abscess formation, grade 3 is transsphincteric fistula, and grade 4 is transsphincteric fistula plus abscess formation, grade 4 is supralevator fistula. Discussion. Anorectal fistula are chronic inflammatory disease primarily affecting the perianal tissue that join the perianal skin and anal canal. These fistula are commonly encountered among the middle-aged women than in women. Gender distribution: it is mainly occurs in males, that is 86%, and most common complaint is perianal region pain, then swelling or post-discharge. According to the Siddharth et al., pain occurs in 72% cases and discharge around the wound occurs in 70% cases. Duration of illness: it occurs less than 6 months. Alcohol consumption occurs in 10%, tobacco is in 2%. There are some comorbidity associated with it: hypertension associated with 10% cases, diabetes mellitus 10%, and chronic of 4%. Intersphincteric fistula occurs in 60% cases, and second is transsphincteric fistula, that is not 40%, that is 26%. MRI grading, that is grade 1 occurs most common, and it is occurs in 60% cases. Conventional fistulogram finding, that is rectal communication detected in 94% of patients, secondary tract only detected in 2% cases, and abscess formation detected in 6%. That is why MRI is superior. Internal opening detected in 100% cases, and primary tract superior to fistulogram for detecting the secondary tract and abscess. Sensitivity and specificity of MRI for the secondary tract is 100%. Sensitivity and specificity for the abscess, that is 100% and 97% respectively. MRI detected more abscess than the surgical assessment. Comparison with other studies, that is the secondary tract sensitivity, Kumari et al. Study, secondary tract sensitivity 93%, secondary tract specificity is 94%, and abscess specificity is 90%. Bernstein et al. Study, fistula tract sensitivity and specificity, that is 100% and 86% respectively. Limitation. One of the primary limitation of the study is relatively small sample size, which may affect the generality of the findings to the broader population. A restricted sample size may not fully capture the diversity of the fistula presentation, potential impact in the study ability to detect fewer common pattern and complication. While 1.5 Tesla MRI provides the useful diagnostic information, it is lower signal to noise ratio compared to the 3 Tesla MRI may limit the detection of smaller complex fistula components. Conclusion, MRI provides the precise definition of the fistula tract along with its relation to the pelvic structure and allows identification of secondary fistula or abscess than conventional fistulogram. And it was also found to be more efficacious and detection of abscess than surgical exploration also. MRI also accurately classifies the type of perianal fistula by assessing its relationship with the internal and external anal sphincter, which is fundamentally critical in deciding the surgical approach and estimating the risk of post-operative incontinence. Its advanced and technology, high resolution imaging enhance the planning of therapy, decrease the rate of reoccurrence, and improve patient outcomes. This is my reference, and thank you.
Thank you, Dr. Shakti. With this, we come to the end of Professor S.N. Sahu-sponsored scientific paper presentation. I would like to thank all the delegates for their participation and as well as our judges. I would like to inform that the lunch is ready in the foyer. Kindly kindly proceed for the lunch.
About the machine, nowadays most of the area is with machines because of the advancement of the hardware and software. So machines are now, most of the vendors, they are using good machines. So that's good. And previously for the generation people, you can have a lot of AI kind of things are available nowadays. A lot of automatic optimization there. Previously we used to see that you have to put it every the automatic optimization happen. So the depth and the frequency and a lot of things have changed. But still you can have, so you can have a lot of, you can be like the grayscale optimization you can do it here. Obviously you